Good morning once again. So we have our second day of Bdcon 2020. So I welcome you all for academic feasts, and we have just a few minutes of delay, and so we'll start with our next session. Our next session, for the session, I'll call upon on stage Professor Dr. Shamul Kundu sir and Dr. Piyush Naik to chair the session. And I'd request the chairpersons to kindly introduce the speakers. Can we have the speaker slides, please?
Hello. So good evening, good morning, everyone. So to start this session, I welcome you all. The speaker of this session is Dr. Karthik Balachandran. He is MBBS, MD, DM in endocrinology. So without much of delay, so our topic of discussion will be 34-year-old male with newly diagnosed FCPD having a HbA1c of 7.8 and unwilling to initiate insulin. So what is the next step and what are the management protocol, and he will discuss in detail. So over to you, sir.
Thank you, Chairpersons, for this generous introduction. There's been a slight delay, and all audience are basically known to me. So this is like doing a kind of a journal club situation. Anyway, we have here a 34-year-old man with the fibrocalculous pancreatic diabetes with an A1C of 7.8%, and is refusing to take insulin. What do we do next? Before we proceed further, a basic few facts about FCPD. India is not just the diabetes capital of the world, it is also the FCPD capital of the world. We have more FCPD cases, or should I say we had more FCPD cases than any other country on earth. And all the other countries put together contribute less diabetes, less pancreatic diabetes than India. One interesting fact is that while China also has huge number of diabetes cases, for some reason it does not have as many FCPD cases. In fact, the number of FCPD cases in China is vanishingly small. So we might say that this FCPD is largely an Indian problem and not any other country's problem. Alarming with the FCPD is that it's not just an exocrine pancreatic deficiency, it's also an endocrine deficiency and a pre-malignant condition. So the primary problem with this condition is not that the pancreas is not just producing insulin or other enzymes, but that there is 100 times increased risk of malignancy. So it's a basically pre-malignant condition. The condition was described some 75 years, but till now we do not know what is the exact cause. Like whenever we don't know what is the exact cause, the usual thing is the two-hit hypothesis, or triple-hit hypothesis, where there is a genetically predisposed individual who is placed in a problematic environment and that causes the disease. Luckily for us, we don't understand the disease, but the prevalence of this disease is decreasing. At least if we look at the population level data from the south of India, we can say that this FCPD is quite rare. And before we proceed further, one of the most important things to realize is that FCPD is by and large a disease of poverty. Now, there are some exceptions. It can potentially occur in other people as well. And we were just discussing with Bodhayan right now that it's the demographics of FCPD appears to be a little different in this part of the country. But by and large, in South, it is mostly a disease of poverty. that rich people rarely get this disease. And this fact profoundly changes the way we approach the disease, the kind of treatments we offer, the kind of counseling that we need to give, and so on. So back to our patient. First thing to find out is it really FCPD or not? If the patient does not fit the usual profile of FCPD, the lean, thin, young patient from a poor background, then sometimes we may have to wonder if it is some other kind of pancreatitis. Two inherited kinds of pancreatitis that can be confused with the FCPD is the CEL gene mutation and HNF1 beta mutations. Both can cause pancreatic dysmorphology, usually lipomatosis and atrophy. Occasionally, it can be misdiagnosed as FCPD. In fact, it has been misdiagnosed as FCPD in some series. But by and large, FCPD is a straightforward diagnosis. Even an X-ray is able to diagnose this condition. It's a straightforward thing. But if case the patient does not fit the usual pattern, and then we may have to think of other diagnoses. So this patient has two issues. One is FCPD, assuming the diagnosis is right. And number two is that he's refusing to take insulin. So we'll take both issues simultaneously. But before we proceed further, I encourage all audience, there are not many youngsters at the back. This is a slide I had just put for the youngsters, to not slot patients into two bins, the ones who accept insulin and the ones who refuse insulin, but rather think of insulin acceptance as an evolving phenomenon. So instead of saying X patient refuses insulin, we might say X patient is not yet ready for insulin. That's a different way of saying it. That is positively looking at the situation. So I would like to call this patient as not yet ready for insulin, and our job is to make him ready for insulin. So whenever we face a patient who is refusing to follow medical advice or who is not very convinced, it is often useful to take away the thinking hat and put on the feeling hat to understand the patient's whole world, to understand what he feels about the particular condition. As such, if this is the first visit, then we realize that Rome wasn't built in a day. In the same way, not all goals can be achieved in a 10-minute consultation. So if we can have realistic goals, you would be definitely successful. And in the first visit, my goals for this patient would be to establish trust and rapport, give tailored information with some optimism. And I do not expect conversion to insulin in the first visit at all. Not only in this patient, but for that patient. So, but the idea of insulin can be planted only in the first visit. And for that idea to be planted and watered in the patient's brain, we must establish some trust and rapport. Without that, the subsequent visits may not happen. And even if they do happen, they may not be successful. So at this point, we move away from the soft skills that are required to manage the patient to the hard skills, the glucose control and the other aspects of the disease. Now, given this patient is refusing to take insulin, it is important to focus on things that he is actually willing to do first. That basically establishes rapport and trust, and we keep the thorny part of the discussion to the end of the consultation rather than at the front of the consultation. So we'll start with the other therapies in FCPD. What are our goals? One is, of course, pain relief. Second is nutrition. Many of these patients are undernourished, may have some micronutrient deficiencies as well. As I said, this is a pre-malignant condition. So our goal is risk mitigation. We have to reduce the risk of cancer. And finally, screening for cancer. If at all the patient, screening is basically a tool for early detection. So pain relief we could do with analgesics, we could do with several other ways, non-opioid analgesics. If it doesn't work, then we might even have to graduate to an opioid analgesics or even refer to a pain specialist. Intractable pain would require surgery, and that would squarely be in the domain of the surgeon. Therefore, we will not discuss more about pain relief further, but drainage procedures such as brace procedures can be done for pain relief. Coming to nutrition, these patients tend to have a higher resting energy expenditure. Not only that, they lose some amount of calories in the form of steatoria as well. So they are chronically undernourished, and that we need to provide them more calories than we would provide a person of that same height, weight of any other disease. So there is a 40% extra requirement of calories. But the bummer is that we can't give bigger meals to these patients because postprandial pain is a big problem, especially when we add some fat to the meals. So we have to optimize protein intake in these patients by giving higher protein intake. In fact, low protein is one of the reasons, or it's thought to be one of the ways in which pancreas gets injured, because strikingly similar findings can be seen in children with kwashiorkor and marasmus in the past, the same kind of pancreatic injury. So we need to increase the protein intake, because the reason why these people develop the condition could be, one of the reasons could be a high carb, very low protein intake as well. Let's say we increase the calories, we optimize the protein intake, and with the help of enzyme supplements, we also manage to push in some amount of fat. If all of this don't fail to increase the weight, then the next step of action would be giving them MCT supplements. That is mixed chain triglycerides. If we give MCT supplements, maximum of 50 grams per day, because anything more than that is known to promote ketogenesis, even in these patients. As such, the risk of decay is very less. But if we overdo the MCT, they can potentially have ketogenesis. And while taking care of carbs, fats, proteins, and in some ways supplements, we also must remember that these patients would be deficient in micronutrients and fat-soluble vitamins, so which needs to be provided to these patients. And one important condition is that they need to be given a slightly low fiber diet, because the fiber in the diet can potentially bind with the pancreatic enzyme supplements that we give and reduce the efficacy of the enzyme supplements. Consequently, the patient will develop postprandial pain if we give fiber plus fat plus pancreatic supplement, because the fiber will prevent the action of pancreatic supplements. Therefore, these patients may require a low fiber diet rather than a high fiber diet. So whenever we think about MCTs, we normally wonder whether coconut oil is a substitute for MCT. The answer is that it's not really, because half of coconut oil is not MCT. It's also long chain fatty acids, and giving just coconut oil may not solve the problem. However, if it is culturally appropriate, for instance, in our part of the country, it's okay to cook with coconut oil, then we can naturally do that. But probably here they don't cook well with coconut oil, I guess. So it's not useful to simply shift to coconut oil just to provide MCTs. So coming to pain relief, one of the most important things we can do is pancreatic enzyme supplementation. For snacks, we can give 10,000 units, and for major meals, you give 25,000 units. Unfortunately, pancreatic enzyme supplements need to be taken multiple times a day, and there are no generics for this thing. It can add up to a financial burden. And as we discussed earlier, this is a disease of poverty, and that some of these patients might have difficulty in accessing the medications. At the same time, we go for non-narcotic analgesics, even consult a pain specialist if needed. And as a last resort, we could go for drainage procedures such as brace procedure. So several ways of containing pain is there, but the most important of them is giving the appropriate dose of pancreatic enzyme supplementation. And in some patients, finding the economic resources to support that would be a challenge. The third pillar of management is risk mitigation. As we know, there is a 100% increased risk of 100 times increased risk of pancreatic cancer. So these patients, if at all they can do one thing to support their health, that should be smoking cessation and no alcohol. Then again, here also framing the issue positively will enhance the rapport and trust with the patient. Instead of saying if you smoke you will get cancer, we can flip it and say if you don't smoke you can reduce the risk of cancer by 100 times. That's the same thing, but it's a positive way of saying things. So worst come worst basis, we also want to detect cancers early, which is by screening. We can clinically look for back pain and weight loss, both ominous signs in a patient with fibrocalcinic pancreatitis or any other pancreatitis. And some authorities believe in checking CA19-9 annually. It's not the standard of care as such, but this is a tumor marker that can be detected if we want to pick up the cases early. Then having discussed all of these things, then we move to the thorny part of the discussion in visit one with this patient. The patient might wonder, do patients with FCBD really need insulin? The answer is majority will do eventually. Majority of the patients will eventually need insulin. And one way to convince the patient is to not just tell the patient, but to show the patient. This is the normal pancreas, and this is the pancreas of the patient. So the patient will know how very different from normal he is by if we sit with the patient and show the images directly. There is a chance that we may move the patient from not even thinking about insulin to maybe wondering, do I need insulin? That doubt is what we plant with showing the images. So he might then think, okay, structurally my pancreas looks different, but is it working fine? And doesn't the A1C of 7.8% an evidence that is reasonably working? The answer to that is A1C is a lagging metric. It takes some time to change. For example, if my A1C is 7.8 and suddenly I develop DKA for some vague reason today, then my A1C will not change. So it takes some time to change, and that needs to be impressed with the patient. Assuming no other issues with the A1C in this part of the country, there could be some hemoglobin abnormalities and all that. Assuming no other issues with the A1C, it appears like beta cell function is not too bad in this patient. And variability is also an issue. Wildly swinging blood glucose is an issue. So this patient could still be a candidate for insulin. But if he is not willing for insulin at the first visit, it's not a big deal, because unlike type 1 diabetes, the risk of DKA is very, very less. So it's not like it's a deal breaker that if he refuses insulin, something really bad is going to happen. So what other tests can we do to help with this decision to initiate or not initiate insulin? C-peptide might look like an obvious choice, but there are no C-peptide cutoffs beyond which insulin has to be initiated. C-peptide is typically lower in these patients, but not as low as in type 1 diabetes. Imaging is usually not of much help in deciding whether to start or not insulin. CGM can be an educational tool if we can show that swinging graph in these patients. But again, remember that this is a disease of poverty. Many of these patients may not be able to afford this kind of CGMs or iPort device if they don't like the idea of injections or pumps and so on. These are high-tech devices. They are also expensive. And many of, at least in my part of the country, they're not going to afford such kind of things. So yes, these are things that can theoretically help, but in practice, none of these actually help. So this brings us to the question of whether to start insulin or not. Whenever we face with the life-changing healthcare decision, we discuss with the patient. The patient is at the center because it matters to him. Benefits, risks, alternatives, and nothing. So the so-called brand framework for deciding on whether to take up a healthcare intervention or not. So if we apply this, what are the benefits of taking insulin? Sugar control is likely to be better, but that benefit does not necessarily, attract a patient. We have to frame the benefit in a way that makes sense to the patient, even any diabetes patient. Saying your blood sugar number is better is very different from saying you'll be more energetic so that you can play with your son. You will be more energetic so that you will be promoted in your office or something of that sort. You have to frame it in a way that makes sense to the patient and that aligns with the patient's aspirations. So that's what the benefit is. What are the risks of insulin? Like, it depends on how we use it, also what kind of insulin. So many variables are there. But by and large, all insulins have the problem of hypoglycemia. Weight gain could also be a side effect in certain patients, but typically these patients are lean. So that is not a side effect that we are actually worried about. So that's not the risk with insulin. The patient will then ask, what can I do? Just some tablets? Yes, plenty of tablets are there. Some 30 years back when FCPD was a big force in the country, we didn't have that many tablets, but today we have plenty of tablets which can be used. Yes, use metformin. Again, if a lean patient, we don't typically prefer those that lose weight, metformin, SGLT2 inhibitors, etc. On top of it, given the insulin glucagon both can get affected in this condition, whether the risk of euglycemic DKA is same as type 1 or more than type 1 or less than type 1 is very hard to predict in these patients. So SGLT2 inhibitors, metformin, those that cause weight gain, weight loss can be pushed to the back. So we can potentially use SUs or PPAR gamma, but we need to know that a lot of drugs are there. that some of them may work differently. One thing we need to realize is that there are no studies such, but we need to avoid DPP-4 inhibitors and GLP-1 agonists in these patients because they themselves can potentially cause pancreatitis. Doing nothing is not an option. So some patients might think, what if I don't do anything? What will be the natural course of the disease? So doing nothing is not an option. So while discussing these benefits, risks, alternatives, and nothing with the patient can identify his or her own reasons as to whether to initiate insulin or not. We are simply there to guide the patient towards the best form of therapy, not impose a particular therapy on a given patient. So with that, we close the first visit. The patient has not decided to take insulin, but that's fine. The visit was a success because we have successfully achieved rapport with the patient. Hopefully, we have gained some trust also, which means the patient will come back for the second visit. In the second visit, our goals, as for the first visit, second visit goals would be to understand the patient and help him find his own why as to whether to take insulin. Why do I need insulin? It could be a desire for a thing. It could be whether an ability to take insulin, reason to take insulin, need to take insulin, and so on. But the simple rule of thumb is that the key to behavior change is actually not speaking, it is listening to the patient. So the only organ that doesn't get us in any trouble is the ear, actually. You know, by speaking, we might say something that can put off the patient, that can offend somebody. It is impossible to offend a person by simply listening to it. That is the most important thing that we should realize. And most of our typical consultations involve asking, listening, and information giving. But at least in where we trained, we had huge amount of patients. It's the same in the country. We are an overpopulated country. Our consultations last hardly 5 minutes, 10 minutes, and in that time, listening basically takes a back seat. But unfortunately, that is the cause for some of the poor outcomes. We need to listen more to our patients. So how do we listen? We resist the writing reflex. When the patient, most of the patients we see, they are not blank slates. They come with their own biases, prejudices, their own ideas. Maybe some relative has taken insulin and died the next day. All kinds of things are there. So when a patient tells his own improper ideas to us, our first reflex is to, no, that's not true. That we need to resist that writing reflex and to roll with the resistance. We don't have to agree, disagree, correct, or analyze or do anything of that sort. We neither confirm nor disconfirm. We basically move the patient towards change, and that is to understand the patient's point of view. And when we understand the patient point of view, we can frame the insulin change talk in a way that makes sense to the patient, in a way that is attractive to the patient. And we listen and empower the patient. That's the basically this thing can be called as rule: resist, understand, listen, and empower. And finally, when the patient could be in any one of these stages. He's either pre-contemplation phase, where he's not even thinking about insulin. Second is an ambivalent contemplation phase. Maybe insulin is for me, maybe it's not for me. It's that contemplation phase. Then there is this commitment phase. I want to take insulin. I am willing to take insulin, but I have still not yet started. And the last is the action phase. We need to mentally slot these patients along this line. Where on this line is this patient fitting? Our job is to move the patient to the right, from pre-contemplation to contemplation to commitment to action. It takes some time. Again, as I said, these things are not done in 5 minutes, 10 minutes, but over a period of time, if we do everything right, the patient comes back for the next visit, and hopefully we'll be moving to visit 3, 4, 5, 6, and so that is the goal. So during the subsequent visit, if the patient has committed to taking insulin, the number one intervention that helps the patient to take insulin is to initiate in the hospital. This has been proven in studies. Emotion is a global study which has it cuts across cultures, languages, and all that. So instead of saying go home and take insulin, you take the first shot in the hospital given by the doctor, and immediately after that we check with the patient whether what do you feel, how do you see this insulin, do you see yourself working with it. One approach is to have a door approach. Maybe try it if it works for you, fine. If it does not work, come back and tell me. So giving the patient that choice, putting him in the driver's seat, helping him see the benefits of insulin as well as experience the insulin firsthand is very important in initiating insulin in these patients. Because as such, we might have had some TT injection or some other intramuscular injection, but unless we have diabetes, there is no way for us to have experienced a 4 millimeter thin needle that is injected subcutaneously. The only way to have experienced an insulin injection or that kind of injection is if we have diabetes. Because we don't have that experience, we confuse that injection, TT injection experience with this. And many patients will be surprised that it's not that big a deal as they thought. So it's very important for us to give them that experience, and that experience has to be checked with the patient. The patient has to hear himself saying that, okay, it's not that big a deal. So whatever we hear ourselves speak, we tend to believe better, and that is important. And of course, we do the technical check, whether he's holding the pen properly. All that's a technical check that we are all taught during our MD days or DM days or whatever. But we are not taught the art of experience checking. So that is also important in these patients. And follow up, and every visit is an opportunity for continuing education regarding insulin, regarding the disease, and so on. And sometimes it may involve different kinds of behavior change. Maybe if the patient is a smoker or an alcoholic, layer of extra complexity to the problem that again has to be tackled in subsequent visits. Sometimes the patients might ask questions based on the internet. Can I get a new pancreas? My pancreas is gone. Can I get a new one? Or can I reverse diabetes? I saw in the Facebook that they were reversing diabetes. Can I do that? So those are different kinds of diabetes. We need to again inform the patient that not all diabetes can be reversed, but all diabetes can be managed. Again, saying you can't reverse is different from saying we can manage it together or something like that. It's basically putting a positive spin, essentially negative situation. And as of now, there have been no major trials or anything on islet cell transplantation, because this is not simply an islet cell disease like a type 1 diabetes. This is a whole pancreas disease. Getting a new pancreas is not an option. So both of these conditions simply don't work. So some tips that we have picked up over the years, I know most of my friends are here, Ian is here, and we all, sort of like learned together, and where we were not specifically taught as to what to do when the patient refuses to listen to you. The power differential was such that we say the patient does. The moment we pass out, we have this situation. We have our own communication styles, but we have not properly analyzed whether it can be improved. There is no magic bullet as to make some patient accept insulin. But the goal is to think long term. It's not like if you fail to initiate insulin in visit 1, it's not such a big problem. If you have to change a goal from successfully converting a patient to insulin instead of eventual success, then almost all of us will be successful. And the way to do that is to slow down and listen to the patient. That is what will speed up the change. And these are some opinionated tips if you might think. So to summarize this talk, there are many ways of glucose control, not only insulin, and we do not have to initiate insulin in the visit 1 itself, but we need to impress upon the patient that that is our overarching final goal. QOL is very, very important, because if we are in pain, if we are depressed, none of us will be able to think straight. So therefore, pain relief and nutrition are very, very important in these patients. Unfortunately, FCPD is a pre-malignant condition with 100x increased risk of cancer. We need to be alert for cancer, signs of cancer. Sometimes we may have to do even blood tests, but we can prevent it to a large extent by avoiding alcohol and smoking, which again requires proper counseling for the patient. As always, we treat the patient, not the numbers, whether it is 7.8 or 6.8. Ultimately, we are simply treating the patient. And that once we remember that, we will be far more successful in maybe giving them better help to this patient. Thank you so much for listening.
Take the questions now.
Okay, so we will take the question. Any question from audience? Yeah, Dr. Rakesh.
Dr. Balachandran, is such a fantastic presentation here.
Thank you.
It's really, I have multiple questions to start with. You are absolutely right that there is a pattern of FCPD across globe, especially in India. So even in India, the pattern of FCPD distribution is predominantly South Indian. And as we move from South India to North and West India, the relative insulin deficiency changes in the relative insulin resistance. And now we are also seeing the increased incidence of FCP in this part of the India, especially at the West Bengal. We are even in Durgapur, we are getting more numbers of FCPD. So what is your take on this? What might be causing change in this? And second part of this, my question is, what are the options among OADs do we really have? Because efficiency of the pancreatic enzymes, it will complicate their delay their gastric emptying. So in those patients, do the AGI will work? Whether it will add to their sufferings or not? What is the role of sulfonylurea and glinides among these FCPD patients? Because already they are having relative insulin deficiencies, and in the due course of time, they are going to have almost nil C-peptide and consequent insulin. So,
yeah, thank you for that nice questions. First, I'll take that. What is causing FCPD? We do not know as of now. Earlier, it was thought that cassava consumption and the cyanogens were implicated. But as of now, we do not know what exactly is causing FCPD. But the demographic shift has been that the incidence has reduced in what was once the capital of FCPD, Kerala, the western part of Tamil Nadu. It has reduced, and most of the FCPD now is diagnosed at a later age group with a higher BMI to start with. It was not the original lean and thin poor patient, but the insulin resistance part also has increased. This has implications for our choice of therapy as well. So when we think about oral drugs, we might possibly classify them into three groups: insulin secretagogues, either direct or indirect ones. Direct as in sulfonylureas, indirect ones like GLP-1 or DPP-4 inhibitors. Then insulin sensitizers like metformin and pioglitazone. And thirdly, the nutrient load reducers, either reduce the absorption or increase the excretion. One would be alpha glucosidase inhibitors, or for that matter, if fat is the problem, that should be orlistat. That prevents absorption or increase the excretion like SGLT2 inhibitors. Each one of these categories might work for a given patient. Unless we know the exact C-peptide, insulin secretion level of these patients, we wouldn't be able to comment whether it will work or not. So if a patient steadfastly refuses insulin, then there is a possibility for us to do a C-peptide in those patients to see whether it is in type 1 level, like absolute deficiency of insulin is there. Then that patient has to be told that the game is up, that we need to start insulin. But there is some residual C-peptide secretion is there, then any of these drugs will work. Now, one might think, why do we need to exhaust the beta cells by giving sulfonylureas or something like that? But I personally do not feel, it's not like we are having a bunch of good choices. We are choosing in a situation where all choices have some problems. So for as long as it works, we may have to give SUs, except that we need to tell them that compared to a regular patient, this patient is at a higher risk of hypoglycemia because the glucagon secretion may also be low in these patients. Recent studies suggest that this glucagon has been actually not so low in these patients, and it tends to come from the L cells rather than the pancreas. So there is evidence that glucagon, oxyntomodulin, polypeptide are also higher in these patients. So consequently, we wonder whether it is coming from the gut. The extra pancreatic glucagon secretion appears to be higher in these patients. So because that extra pancreatic glucagon secretion is higher, then the risk of hypoglycemia with sulfonylureas may not be as high as we once thought. So sulfonylureas may still work in these patients, especially the ones with the lower risk of hypoglycemia like glycoside. So I might give glycoside or even the PPAR gamma agonist or metformin if the patient is having significant insulin resistance. But I would keep the SGLT2 inhibitors to the last. AGIs, of course, can be given. But because of that risk of EDK, I might keep it at the last. Yeah.
Thank you. Apart from this, just one another question, since you are the most southern part of the last question. So what is your experience in patient having PPA gamma gene mutation in your part of the country?
Gene mutation?
PPA gamma with severe PPA gamma gene mutation, experience with very severe insulin resistance.
Oh, I haven't come across any such thing actually.
Yes, polymorphism.
polymorphism. No, we haven't. As a matter of fact, CMC well does kind of next generation sequencing for any young diabetes that's neither type 1 nor type 2. We might, and it's reasonably cost effective, but still, since there is very poor, recently they have published that there is a poor genotype phenotype correlation. It might come up with some gene, but we will not be able to interpret what that gene means to us or to the patient. Consequently, we are a little conservative in sending genetic tests for young diabetes patients.
Thank you, sir. Thank you. It's a nice presentation.
Yeah, and just Dr. Karthik, one quick
Thank
question to you, please. So
Well,
as always, you have started today's session on a fantastic note. So thank you for that. So just a quick submission that I think the best person to motivate another person to start insulin would be another person who is already already taking insulin. So I would request maybe Amitabh sir, sometimes maybe next year we can do a sharing session or something small between persons, like somebody who is already taking insulin, he will or she will motivate others. So that will be a big thing. Persons will also be,
Yeah, actually, they studied
rather
this
than
in
a
study
doctor.
called Dawn and Emotion. 2 studies are there, global studies. Not many Indian representation from that. They found what are the things that help the patient decide on insulin, whether to go for insulin. They initially thought this would be the thing, experience sharing somebody, some kind of group therapy, but it was not very effective in the Western patients. Probably it might work in Indian patients. The Western patients probably are not swayed by the fact that some other person took insulin in that given situation. Maybe Indians would be little different. Yeah, that's the thing.
Thank you, Dr. Balachitran, for excellent lecture. And because of the shortage of time, we cannot spare much time for question and answer session. Please be within 1 or 2 questions. The next speaker is
Sir, just because he has to catch a flight, so we'll just give his request Professor Kundu sir to kindly felicitate Dr. Karthik for us.
Let's move on to the next speaker, Dr. Amritabha Ghosh, who is an eminent endocrinologist, will be talking on hypothyroidism in pregnancy, what's new. Always this is a challenging subject because we have to ensure the growth of baby. Let's listen. Dr. Amritabha Ghosh, please start your deliberation.
Thank you, sir. First of all, I'd like to thank the organizers for giving me the opportunity to come and speak on this podium. So I'll discuss the physiologic changes related to thyroid in pregnancy and the changes in thyroid function tests. Quickly, subsequently, I'll move on to hypothyroidism, subclinical hypothyroidism, hypothyroxinemia, and antibody positivity. So the various physiological changes related to the thyroid in pregnancy are: there is an increase in thyroid gland, about 10% in iodine sufficient areas and up to 20 to 40% in iodine deficient areas. There is increased production of thyroid hormones. Placental HCG again cross reacts with the receptors and stimulates the TSH receptors, increasing thyroid hormone secretion, which in turn again suppresses the TSH. There is increased thyroxine binding protein, increase in renal iodine excretion, which in turn leads to increased iodine requirement. So this slide summarizes the usual changes in thyroid function that result in pregnancy. There is increased thyroxine binding globulin, increased total T4 because of that, and as discussed just a while back, there is decrease in TSH. In automated immunoassays, often free T4 reduction is noticed, although in other methods like centrifugation and LCMS, this change is not observed. So this is actually an assay interference, which leads to an apparent decrease in FT4. Hypothyroidism in pregnancy is maternal hypothyroidism is defined as TSH concentration elevation beyond the upper limit of pregnancy specific reference range. So I'll be discussing what is this pregnancy specific reference range. While isolated hypothyroxemia is defined as free T4 concentration in the lower 2.5 to 5th centile and in the presence of normal TSH. So initially in 2011, ATA had come out with guidelines of management of hypothyroidism in pregnancy, where they had given a cutoff of upper limit of TSH as 2.5 in first trimester, and in second and third trimester, it was 3. So this cutoffs were based on studies, about 6 studies, which included approximately 5,500 subjects. Subsequently, based on the availability of further data from large number of subjects, these cutoffs were done away with in the subsequent edition of the ATA guidelines. Substantial population differences are observed in TSH upper reference limit. Usually only a modest reduction in upper reference limit, around 0.5 to 1 milli-IU per liter reduction compared to non-pregnant state is observed. And these differences in population to population differences again is attributable to the iodine sufficiency state as well as the assays used. So it is very important to have, when available, trimester specific pregnancy ranges for a particular population developed in one's own institute or laboratory based on the population which they are catering to, which is assayed in those who have sufficient iodine intake, do not have history of any thyroid disorders. But this is often not practical, in which case we can use TSH reference range from a similar patient population using similar TSH assays. So, are there any recent data available from India? This data from North India showed that among 604 participants, the 5th and 97th percentile of TSH were 0.64 to 7.8, while those at low risk in this cohort had TSH range of 0.59 to 4.5. Luckily, we have in West Bengal data from IPGMER, which was recently published in 2020. So about 80 women each in first, second, and third trimester were involved. The reference ranges 2.5 to 97.5 percentiles have been mentioned here. TSH in the first trimester is 0.19 to 4.34 using the Imulite 1000. For second trimester, it is 0.46 to 4.57, and for third trimester is 0.61 to 4.6. Similarly, usually it is said that T4 starts to rise from about 7th week of pregnancy and continues to rise till 16th week of pregnancy. Around 5% rise in total T4 is observed every week. And by 16th week, T4 becomes about 1.5 times the range. But this study did not show that much in T4. The T4 reference ranges that were observed were 5.9 to 12.9 in first trimester, 7.4 to 15.2 in second trimester, and 7.9 to 14.9 in third trimester. Moving to hypothyroidism in pregnancy. What are the adverse outcomes associated with overt hypothyroidism during pregnancy? So overt hypothyroidism is defined as TSH above the upper cutoff limit with low lead to premature birth, low birth weight, gestational hypertension, pregnancy loss, and low IQ among the offspring. So the adverse outcomes with overt hypothyroidism are very well established, and when it is present, it should definitely be treated. There's one recent study which also showed that maternal hypothyroidism is associated with adverse cardiovascular disease risk. So it was done in more than 1 million population who were followed up for a long time. The magnitude of association was more pronounced when the exposure was during pregnancy. Subclinical hypothyroidism is also often said to be associated with adverse outcomes in pregnancy. So what adverse outcomes are associated with subclinical hypothyroidism during pregnancy? Well, as compared to overt hypothyroidism, subclinical hypothyroidism is variably associated with increased risk of adverse outcomes in most but not all studies. So this recently published meta-analysis showed that subclinical hypothyroidism was associated with higher risk of pregnancy loss, placental abruption, premature rupture of membranes, and neonatal death. Also, there is a tendency towards higher risk of preeclampsia. So this preeclampsia, higher risk of preeclampsia was further established in this meta-analysis, which included only prospective cohort studies, and compared to euthyroidism or subclinical hypothyroidism during pregnancy was associated with higher risk of preeclampsia. There was a U-shaped association of TSH with preeclampsia. What other adverse events are there? Can it be mitigated by appropriate treatment initiation at an appropriate time? Well, this retrospective cohort study among about more than 5,000 pregnant women, where 843 were treated while 4,500 were not treated. Thyroid hormone treatment was associated with decreased risk of pregnancy loss among women with subclinical hypothyroidism, especially those with pre-treatment TSH concentrations which were a bit on the higher side, that is more than 4. The effect of treatment of subclinical hypothyroidism on the outcomes of IQ is not very well established, where total 677 women with subclinical hypothyroidism underwent randomization or placebo treatment for subclinical hypothyroidism or hypothyroxanemia. So 2 groups were used in the study, one with subclinical hypothyroidism, and another group that was studied was hypothyroxanemia. So in both the groups, treatment with levothyroxine was not associated with better cognitive outcomes. However, we should observe here that the randomization time was around 17 weeks. So the usually brain development starts by 5 weeks, and so this if it is initiated late, it may not be effective in achieving a desired outcome. So absence of evidence does not mean absence of efficacy all the time. It will depend on when the patient was treatment was started, how severe was the condition, and what was the duration of hypothyroidism. So treatment of subclinical hypothyroidism to achieve better cognitive outcomes should always be considered, even if there is no available evidence. So particularly risk of pregnancy loss and preterm delivery has been found in relation to elevated maternal TSH, particularly when there is an elevated antibody titer also. And in those with TPO antibody negative, efficacy is observed, particularly when TSH levels are at a higher range. So should we treat subclinical hypothyroidism in pregnancy? Yes. What should be the approach? If the TSH is less than 2.5, there is no further work about treatment. If TSH is more than equal to 10, treat it. If it is between these two, get one anti-TPO antibody titer. If the anti-TPO is positive, TSH is between 2.5 to the upper limit of the reference range, consider treatment. If TPO is negative and TSH is between 2.5 and upper limit of range, there is no need to treat. If TPO is positive and TSH is above the upper limit of reference range, treat. If TPO is negative and TSH is above the upper limit of reference range, consider treatment. So what adverse outcomes are associated with isolated hypothyroxemia? Well, some association has been reported in between hypothyroxemia and cognitive development of offspring. There is uncertain effect on prematurity and low birth weight. Till the last guidelines were published, no studies existed which showed that LT4 administration has been shown to ameliorate the harmful effects. Even the study we discussed a little while back in published in NEJM, there was no beneficial effect of levothyroxine treatment on the cognitive outcome in those with isolated hypothyroxemia. However, this recent study published in Frontiers in Endocrinology, this was of course a non-randomized intervention study. Pregnant women who were treated with levothyroxine showed reduced rate of miscarriage and decreased admission to NICU. However, we should see that this study, the outcomes are just statistically significant. So this should always be taken with a pinch of salt. As of now, there is insufficient evidence to treat isolated hypothyroxemia. What is the optimal method of treating hypothyroidism in pregnant women? Well, LT4 is the drug of choice. Other preparations, particularly the upcoming T3, is not recommended. It is reasonable to target TSH in the lower half of trimester specific reference range if it is available. Otherwise, we can target it below 2.5. How frequently should we monitor? We should monitor every 4 weeks till mid-pregnancy and once at 30 weeks. We should monitor those at risk of developing hypothyroidism, such as those who are antibody positive or have undergone hemithyroidectomy or have undergone radioactive iodine therapy. Or of course, those who are having overt or subclinical hypothyroidism. So how do treatment approach differ compared to non-pregnant? We should remember that thyroxine requirement increases during the early part of pregnancy. Accordingly, once the pregnancy is confirmed or suspected, thyroxine dose should be increased. So increased requirement can occur as early as 4 to 6 weeks. About 50 to 85% of women may require increase in thyroxine dose during pregnancy. So major factors influencing the dose increase are underlying etiology. Those without functional thyroid tissue are more likely to need dose. And again, the preconception TSH levels. If TSH levels have been on the lower side, there may not be a requirement for TSH thyroxine increase. So the recommendation is women who are planning pregnancy, serum TSH should be evaluated and levothyroxine dose adjusted. So various cutoffs have been suggested, like less than 1.2 or less than 2.5. Less than 1.2 is a bit strict and may often lead to subnormal TSH levels. 2.5 is an appropriate cutoff. Hypothyroid patients receiving levothyroxine once pregnancy is suspected, as I discussed, should increase the dose of thyroxine by 20 to 30%. One easy approach is to increase one tablet each on each weekend. Like patient will take 9 tablets in a postpartum. Once delivery has been achieved, we can go back to the pre-conception levothyroxine dose. Some women in whom levothyroxine was started at the time of pregnancy, we can even consider stopping it, provided the patient's dose requirement was less than equal to 50 microgram, and subsequently we can follow up the patient after 6 weeks. What to do about patients who are autoantibody positive but euthyroid? They should definitely be monitored because they have a chance of progressing to subclinical or overt hypothyroidism during the course of pregnancy. Currently, there is insufficient evidence that it reduces the live birth rate or preterm delivery. Still, the current recommendation suggests that treatment should be considered, particularly those who have a history of pregnancy loss. However, these 3 recent studies have failed to show any benefit of starting levothyroxine therapy on those who are antibody positive, however, euthyroid. This T4 life trial involving around 187 women failed to show any beneficial effect of starting levothyroxine compared to placebo. Similarly, another study published in NEJM, here the treatment was started pre-conception. In spite of that, levothyroxine failed to show any beneficial effect in pregnancy outcome. Also,
Dr. Ghosh, wind up.
yes, sir, this is the last slide, sir. This is another study which failed to show any beneficial effect. So to summarize, pregnancy is associated with significant changes in thyroid hormone physiology. When available, population and trimester-specific pregnancy hormone reference range representing a typical population should be used. Overt hypothyroidism should be treated urgently. Treatment should be considered hypothyroidism, particularly those with antibody positivity. Currently, there is little evidence to support treatment of patients with isolated hypothyroxemia or euthyroid patients with thyroid autoantibodies. Thank you.
Thank you, Dr. Ghosh. Lecture touching every point in the issue, but because of the shortage of time, we cannot take questions. So, should I move to the next session?
Sir, I would like to please stay on stage for please. I would like to request Dr. Piyush Naik to kindly facilitate our speaker, Dr. Ghosh, please. And I would now like to request on behalf of BDF, Dr. Rajan Palui to kindly felicitate our chairpersons, Professor Kundu and Dr. Piyush Naik, please.
We'll have our second session. It will be chairperson by Dr. Harsh Durgia. He is from Rajkot, Gujarat, endocrinologist. Next is Dr. Arnab De. He is hepatologist from Mission Hospital, Durgapur. And Dr. Subham Das, consultant diabetes. He is practicing at Durgapur. So kindly come onto the dais and They will introduce our speakers.
Yeah. For our next session, we have the topic, a very interesting and a very pertinent topic these days, CGM versus structured SMBG, who, when, and why. And we have a very eminent and young and dynamic speaker amongst us, Dr. Deep Datta, who is an endocrinologist. I would now like to request Dr. Deep Datta to take over the session, please.
Thank you so much, sir. It's always an honor to be come to the city of Durgapur, very close to my roots. And thanks to the organizers for inviting me and making me a part of this huge scientific extravaganza. And the topic is very relevant. Should we use CGM or should we use SMBG? There's a lot of, I would say, industry push for CGM. So is CGM for everything? Well, in the next 20 minutes, I shall be highlighting to you the evidences regarding the use of CGM and SMBG. So why are we talking of CGM and SMBG? Simply because we want to ensure that our patients not only achieve the glycemic targets, we know that we would love to keep the HbA1c of all our patients living with diabetes to at least less than 7. If we can do it for less than 6.5, that's awesome. But I think most things in life, we know that we have been told that the journey is perhaps more important than the destination. Of a patient, be it with type 2 diabetes or type 1 diabetes, is to reach the glycemic targets is frittered with episodes of low blood glucose or hypoglycemia or episodes of high blood glucose. So, as goal of treating physicians, our job is to ensure that they have as smooth a journey as possible, because now we know that it is not only important to achieve a good to do that with minimal glycemic variability, because they also have an independent impact on the burden of microvascular and macrovascular complications. And hence, in a classical OPD, if a patient walks into us after many months with the HbA1c report and the fasting and the postprandial blood glucose values, most of the times we will see a discordance between the fasting and the postprandial lab report and the HbA1c. Especially in the Indian setting, where we tend to have a late dinner, a late lunch, and a heavy evening snack, we tend to have a greater amount of evening hyperglycemia, be it the pre-dinner or and a relatively better control post-breakfast values than fasting glucose. So most of the time they'll have a very good post-breakfast values, but the HbA1c would be around 9 or 9.5. There comes the importance of SMBG. The word is self-monitored blood glucose. So it is about empowerment of the patient. The patient does it himself or herself. So that's a very positive aspect to it. Like Dr. Karthik beautifully highlighted how in a day-to-day practice, it's important to empower the patient and give positive retributes to whatever they are trying to do. So this is 3 different patients. If you see, 3 of them are having a similar HbA1c of 7%. But if you see the patient example 3, the 100% of the blood glucose values are in the so-called good range, a nice to have ideal scenario. 2, the example 1, where it is a predominant amount of hypoglycemia with a few episodes of hyperglycemia. Actually, very 18% of the blood glucose in the so-called the ideal range. So same HbA1c can have staggeringly different blood glucose parameters. So unless we do a self-monitored blood glucose, we'll be missing the whole picture. Why SMBG in routine practice? Why not CGM? I shall come later, because SMBG is easier to do. You have a glucometer, the cost of glucometer, the cost of glucose steps have come down drastically. This is the typical SMBG chart which we share with the patients. It might be overwhelming to see that I have to check 7 times blood glucose in a day. That is 3 post meals, 3 pre-meals, 3 post meals, and 3A. Definitely not. These are just a pattern generators. So in a patient who walks in my clinic with type 2 diabetes, and initial HbA1c of maybe 9, more than 10 or so, we are starting a new treatment or we are bringing a drastic change to the pre-existing treatment, it's a good clinical practice to go for a more frequent SMBG. Like we check 2 to 3 times a day for the first week to 10 days. Maybe some days you can check a fasting post breakfast or a pre-dinner. The next day you can check a pre-lunch, post-lunch, and a post-dinner. So it gives a good pattern generator. And we need to empower the patients. If they're checking at home, what should they be doing with the values, right? Of course, they'll be coming back to us with the charts after a week or so, but they can do small things at the home. So if they have a predominantly post-meal rise, I'm sure your diabetes educator would be teaching them about a low-carb, high-protein diet plan. So we need to tell the patient, if your post-lunch is suddenly very high, what did you have in lunch? So you had a greater amount of carb, you need to cut down on the carb. So patient feels very positive about it. They feel that they're doing something about it themselves. So we can get good patterns, which meals are more difficult to control the blood glucose. And once the patient, we're talking of simple type 2 diabetes here, once we get a good pattern for a period of 10 to 14 days, then the patient need not check 3 to 4 times. They can check once a week, maybe twice a week or thrice a week, maybe fasting after 4 or 5 days of pre-lunch, after another 5 days of pre-dinner. So the things aren't fine. So in a routine, simple, stable patient with type 2 diabetes, HbA1c around maybe 7 or 7.5, where the majority of the patients, if they check maybe once a week, on Sundays or a different days, different times, is good enough. 8 to 10 SMBG pricks in a month is good enough for them. The situation is drastically different when we are talking of type 1 diabetes or maybe a brittle type 2 diabetes on basal bolus insulin regimen. In them, we have 4 shots of insulin. In them, maybe checking glucose once a day, which most of the patients do. A lot of patients, when we ask them to do SMBG, they typically come with the whole month fasting blood glucose values. They would not have checked the lunchtime or evening time. So we tell them, you have wasted so much of your effort, you have pricked yourself, but we have missed the picture. We have only one value in the morning, which is coming pretty good, but your HbA1c is still high, maybe whatever it comes. So we tell them, please check at different times. The message should go that it is not only about fasting glucose control, it's about the entire day blood glucose control, which contributes to SMBG. So in type 1 diabetes, we typically need to do at least 3 pricks a day, at least 3 pre-meals. And if you see that the pre-meals are well controlled, you may shift to one of the post-meal, post-lunch or post-dinner. If they can do 4 pricks a day, that's even better. But yes, the cost of treatment goes up. Not only the insulins are costlier, the cost of monitoring is also costlier. So that's why there's a greater role of CGM in type 1 diabetes than perhaps in simple plain Jane type 2 diabetes. Now let us look at the evidence behind it. There's a lot of evidence. These are not recent papers. These are papers published in the last century, which showed that in good cohort of patients, more than 2,800 patients, people who did SMBG in US, is American data, they found that, and the patients were empowered to bring about subtle change in their treatment patterns. They found that not only the patient had a better glycemic control, they had a general sense of better well-being. So we have enough data showing that these people who do SMBG, they had overall lesser occurrence of depression, they had a better quality of life, they're performing much better in their, not only in their domestic life, but also in their professional life. And in America, if you look at the cost of therapy, also the cost of healthcare comes down drastically. They were taking lesser amount of sick leaves, they were taking lesser amount of leave because of hypoglycemia. So overall, it had a big positive churn on their day-to-day life. Another, there's a California entire state database where they analyzed data from more than 24,000 patients. They could demonstrate in their cohort that people with type 1 diabetes who did regular SMBG, there was an additional 1% lowering of HbA1c. That translated in type 2 diabetes to around 0.6% additional lowering of HbA1c. Even in simple early type 2 diabetes managed with just diet and lifestyle changes, patient did in HbA1c, they could document an additional 0.4% reduction in HbA1c. That's like the glycemic efficacy of HbA glucosidase inhibitors, if you look compared to other diabetic medications. So we should not underestimate the beauty and the power of SMBG. So another study again showing that the same data showing that how SMBG has an additional anti-hyperglycemic effect because the patient feels better. The patient can do certain changes with their diet and lifestyle. A person who is not working out, not going for exercise, he sees, okay, I went for walk on 2 days of the week and my sugar parameters are much better. The 3 days I did not go, my blood sugar values were much higher. So they can see certain results and they can work on it on a day-to-day basis, and they need not wait for 3 months to go to their treating physician and then bring about some change in their treatment patterns. So I think this is we have already discussed. So it's not surprising all the guidelines, be it the ADA guidelines, the EASD guidelines, even the Indian guidelines, they strongly recommend SMBG in across the spectrum of diabetes, whatever form of diabetes you are managing. Just that the frequency of SMBG would be the least in the well-controlled diabetes, would be the highest in type 1 diabetes, and would be anywhere intermediate across all the people in the middle, be it FCPD, be it pregnancy and diabetes, or be it type 2 diabetes, more advanced disease on multiple shots of insulin therapy. So the question in SMBG always comes, what values to check? I think dictum, fix the fasting first. Once we have fixed the fasting glucose, we should be focusing on the values in the pre-lunch, post-lunch, or pre-dinner, post-dinner. Typically in type 2 diabetes, when we augment to a basal insulin with daytime sulfonylureas or daytime OAD regimens, we typically adjust the insulin dose in night based on the fasting blood glucose. Once that is controlled, I think we should be focusing to control the post-lunch or post-dinner or the post-breakfast values. So SMBG provides snapshot and CGM would provide the entire picture. So you will have a multiple snapshots taken at every 5 minutes, the lot of huge data points. So you ultimately, the patient is overloaded with a lot of data, and the routine doctor is also loaded with a lot of data. So there is no role of routine CGM. You would be not only adding to the cost burden of the patient, it is cost effective in your busy OPD. If all your patients start working with CGM graphs of 10 to 12 pages, you are not going to finish your OPD on time, and it is not going to add to any other benefit either to you or the patient. Very simple. So how does CGM work? It works on a similar technology. The only difference, it checks, there's a cannula there under the skin, and it measures the interstitial blood glucose. It uses the amperometric method, a technology similar which is used in glucometers. It may be working on the glucose oxidase method or the glucose dehydrogenase method. The glucose dehydrogenase based assessments are believed to be slightly more reliable than the older technology of glucose oxidase based assessment. You can have, this is a typical CGM device which can show the instant value. You can see the previous values. You can see small amount of curves. What is important that they have alarms. You can set your own alarm. Say you can set an alarm at say 200 milligrams per deciliter. So if the blood glucose, whenever it crosses above that, the alarm will beep. You can set a hypoglycemia alarm less than 70. Whenever it crosses, it will beep. So initial few days, it is pretty good. The patient, okay, something is happening. But if the alarm keeps on beeping all throughout the day, all throughout the night, it's caused a lot of fatigue. It adds the stress or anxiety. It's not all hunky dory. It's not like I have put a CGM machine, the life is over. The story actually starts there, and it's a very intensive and maybe a tiring story, not only for the patient who or the treating doctor. We keep on getting WhatsApp messages in the middle of the night. Doctor, my alarm is beeping at 2 a.m. So what do you do? So you need to train, you need to have a team to handle the CGM. Many times we have only 24 hours for ourselves, our family, our patients. So if you have a lot of patients on CGM, it is a good practice to have a trainer in your clinic who can address the small clock, the alarm calls if the patient will be sending you the initial few days. When the patient is more comfortable, the amount of calls or WhatsApp message, you'll be getting good word. So that brings us to the type of CGM.
SGLT2 inhibitors versus DPP4 inhibitors. And here they have directly measured the effect of beta cell function in the form of HOMA beta along with pro-insulin to insulin ratio. And you can jollily see that DPP4 had outsmarted SGLT2 inhibitor by protecting the beta cell function. So here another important aspect is that if you can see in the circled area, alpha cell dysfunction is one of the most important function in diabetes patients because it's not only insulin deficiency, there is hyperglucagonemia in diabetes patients. And this causes lots of problem, including NFLD. Shomikda might be agreeing with me because of there will be glucagon resistance at the level of liver. We are not just outlooking glucagon part. We are not seeing at all. And DPP4 inhibitor directly suppresses glucagon. Even in patients who are on SGLT2 inhibitor, because we know that SGLT2 inhibitor will increase the glucagon levels and it will perturb the insulin glucagon ratio and thus predispose the patient towards euglycemic A. So what happens? DPP4 directly acts on here also. So you get pathophysiologically three important functions. One is you will improve the beta cell function. It will suppress glucagon, and thirdly, there will be some effect on insulin resistance also. So pathophysiology, it's directly targeting. Second thing is that durable glycemic control. How we can see? You see, this is the latest evidence from the verified trial. So once you are going to make a choice, please verify. So what this trial has shown, the glycemic durability of an early combination therapy with vildagliptin and metformin versus a sequential metformin monotherapy in newly diagnosed type 2 diabetes. It was a 5-year multicentric randomized double-blind controlled trial. You can see this is a very important trial because you see after a run-in period of the metformin part, there was a period one when the patients were randomized between metformin plus vildagliptin versus metformin. And after that period one is over, a certain group of patients who were not controlled in metformin, the exact topic of our debate, they were switched to metformin plus vildagliptin, and they are again followed up in the trial. So what we have seen in those patients who has shifted from metformin to metformin vildagliptin, they had a reduced risk of probability of initial treatment failure. That means their HbA1c was consistently maintained below 7%. The risk of time to a second treatment failure was also reduced. And this was happened throughout the 5 year of the study. So this suggests that how much DPP4 inhibitor along or after metformin, if it is not controlled, will give durable glycemic control. This was true for vildagliptin here. So clearly it suggests that in newly onset diabetes mellitus patients, if you add vildagliptin along with metformin, it will definitely give a durable control. This is the Cox proportional hazards ratio chart, and the upper panel shows that the risk of losing the glycemic control was much less in metformin plus vildagliptin group compared to metformin alone. So another interesting factor from this trial was, if you see the subgroup analysis, the benefit was even greater in young onset type 2 diabetes, less than 40 years. Nowadays, lots of patients are in less than 40 years, they're developing diabetes. The exact figure at present in India, it is not known, but roughly 1/3 of the total diabetes patients will have. So we need to give them a good glycemic control even before they develop cardiovascular disease, and we talk about all those things. So how is the difference? It is between 48% to 24% reduction in the treatment failure. So this holds true, DPP4 inhibitor holds true for young onset diabetes also. So after we have seen that DPP4 gives a good durable glycemic control, let us see some head-to-head comparison. So what happens in this kind of molecules, they're never tried head-to-head, because possibly the pathophysiology is different or because maybe different issue. So different trials have shown, like it has combined SGLT2 inhibitor, DPP4 inhibitor versus a DPP4 versus a SGLT2, but head to head are very less. Only 3 trials as of I can find in the literature. That was back also in 2013-14. But this is a nice meta-analysis in 2014, which has shown that the glycemic efficacy between SGLT2 inhibitor and DPU4 inhibitor is quite same, particularly in less than 26 weeks. But if you go to more than 52 weeks, that is more than 1 year, then there is like little bit of edge of SGLT2 inhibitor, as my co-speaker has told. But how much it is? You see, it is only 0.8% with SGLT2 versus 0.74. Does it matter clinically? I don't think so. So, and if you see in 52 weeks, 0.66% versus 0.54%. So almost similar efficacy. Another thing that is very important is that if you see the number of patients who have achieved a target HbA1c of less than 7 at 26 weeks and 52 weeks, there is no difference. So possibly SGLT2 inhibitor and DPU4 inhibitor doesn't have that much, I mean, none of them have that much age, and they're at similar, platform considering achieving HbA1c. But again, we have to remember that there are dearth of trials and there are less head-to-head trials, and all this data are derived from secondary analysis of different trials. So another thing I would like to highlight that DPU4 inhibitor, the HbA1c reduction will be depending on the baseline HbA1c. How come it is? If the baseline HbA1c is 8.5, then DPU4 inhibitor will have a favorable effect compared to SGLT2 inhibitor, which will give more HbA1c reduction in when the HbA1c will be more than 8.5 to 9. So in patients who will have a HbA1c less than 8.5, DPU4 inhibitor is as good as SGLT2 inhibitors. Sorry. So again, another interesting thing, and persisting, we're treating Asian Indians. We're not treating Caucasians. We are from all the data coming from other big trials, no? So you see, as I have told, Asian Indians already will have very less beta cell function. So here you can see DPU4 inhibitor exhibits a better glucose lowering efficacy compared to Caucasians in Asian. This is a very important point which we have to explore. So how much? Another interesting point is that HbA1c lowering will be in BMI in less than 30, particularly in the subgroup of 24 to 26, which all our patients are. Our patients are not that much obese. We who have BMI of 30, 32.5. Why we need 3 to 4 kg of weight loss with SGLT2 inhibitor in them? Just give them a good lifestyle, they will achieve that weight loss. But the fundamental problem is that they're having visceral fat and less beta cell function. And you see the HbA1c difference between Asian and whites, it's almost 0.3%. So we have a drug which will act on a lower BMI, improve beta cell function. It acts better on the Asians, not on the Caucasians. So after this, I highlight few bit of limitations of the SGLT2 inhibitor, because that is very important to understand before we jump into so much robust conclusions. Okay, so this is the latest meta-analysis. This is from Diabetology in 2022, September only it has been done, but this clearly summarizes these famous trials have been told by my co-speaker, this canvas, empiric and all those things. And he has rightly pointed on the left part of the thing, that is there is improvement in the MES outcome, heart failure outcome and end-stage renal disease outcome. But you see the figure, the figure is very important. You need to understand the figure. What is the thing is that for 1,000 persons who has to be treated with a SGLT2 inhibitor for 3.5 years, how many messes you are reducing? 9. How many out of that for heart failure is 11, and renal disease is only 10 patients for 3.5 years. Are we having a cost-effective analysis? I mean, cost-benefit ratio? I'm not quite sure about that. Most importantly, you see the side effects. Genital infection, 36 patients will have genital infections more. And mind you, many patients will have to discontinue because of balanitis and balanoposthitis. This is clinically very much evident. Second thing, they will have more ketoacidosis, but these trials, they were not powered to show euglycemic decay incidence. It just was So they have glycemic decay, but I feel this must be rare because of the pathophysiology. So there is a big question mark on these outcomes. Why? I'll discuss. You see, all these trials, they don't have any active comparator. All have placebo. So what happens if you are controlling SGLT2 inhibitor with a placebo? In the placebo group, the HbA1c is persistently 8.5 to 8.6, because at the baseline, all those trials have HbA1c somewhere between 8.5 to 8.6. So placebo group, you are keeping 8.5 and following up for 4 years. So you are obviously will have more cardiovascular deaths or cardiovascular events on those age group. I could not understand what is, there should be active comparator based this thing. Second thing is that if you see the declared TIMI trial, there is a 10% patients who already had a heart failure at entry. So if you give a drug, SGLT2 inhibitor, which increases natriuresis, decreases intravascular volume, they are going to improve. And you are putting that as it is. This is the glycemic effect which has been given all the severe outcome results. So third thing is that many patients, 4 to 6% of patients received an open level SGLT2 inhibitor in both the trials based on the physician's discretion. So we need to go deeper on all those trials before we jump into the conclusions. And there is no link of SGLT2 inhibitor with a type 2 diabetes. Substrates change from glucose to free fatty acid ketones and hypoxia inhibiting factor stabilization. That gives all these outcome, good CV outcomes, not the glycemic parameters and all those things. There are certain other things. And if you see the declared TIMI 58 trials also, if you treat 100 patients for whom daily treatment was indicated for a median period of 4.2 years, just to prevent one heart failure. Okay. And for Canvas has problems with the sample size calculation, because initially it was told that the sample size was based on HbA1c reduction, but then they again recalculated, settled down on a different note, but there are problems. So safety profile also is very important. The DP4 inhibitor we are using from 2006, it has a very good safety profile. Apart from increasing a slight risk of acute pancreatitis, which is clinically possibly not relevant, I have recently reviewed DP4 inhibitor and acute pancreatitis and pancreatic cancer. I have found a mild increment in the acute pancreatitis risk, but that is not clinically significant. Okay, but on the right-hand side, you can see SGLT2 inhibitor, lots of side effects, particularly GMI, euglycemic decay, postural hypertension, dizziness, and all those things. And we are experiencing only 6 to 8 years. Let it settle down a little bit, then we'll understand how many side effects will come up. So you can see the increased risk of euglycemic decay along with genital infection. So this was my review. So finally, the guideline recommendation, all we are concerned about the cardiovascular outcome, but I have already told you about the loopholes of those trials. We need to dig deeper in those. Better the letter to us rather than the trials. I find it very fascinating to read the letter to editors against those trials rather than those trials. So on the right-hand side, you can see, particularly in an Asian perspective, which have lower BMI, you need to protect our beta cells. DP4 inhibitor still have a choice. And rightly so, ICMR guideline in 2018 rightly backed up DP4 inhibitor as a second choice when the HbA1c is more than 9%. So what we have in summary, DP4 inhibitors gives a durable glycemic control. It improves beta cell function, particularly in Asian, all our patients. It's a weight neutral drug, better efficacy in young onset type 2 diabetes, no risk of hypos. There is excellent safety profile known from 2006. Dose modification very rarely required in renal dysfunction. It is well tolerated in old and frail persons. And we will be treating a majority of persons who won't be having any CV issues at the early part of the diabetes. So in precision medicine, definitely it has a place. Thank you.
So thank you, Dr. Oyon. That was again a very wonderful way of defending the case for DPP4 inhibitors. So before we close this academic bout, we have a very round of rebuttal and sur-rebuttal. 2 minutes for rebuttal, 2 minutes for rebuttal. So the logistic staff to set the clock at 2 minutes. I'll first call upon the proponent of the topic, Dr. Shottam, to speak against what Dr. Oyon has said. You just have 2 minutes for the final bout. You can stand.
So, can I start? Okay. So my dear friend has given some excellent points, no doubt about that. Perhaps we need to come more across the concept of YY paradox. And he was a bit more obsessed about treating the sugars than treating the patients. That's good, but I will treat the sugars as well as the patient. And as far as the YY paradox, each and every Indian diabetic patient is fat. And when we decrease the fat mass, we know what advantage we give to the patient. That's why just going by sugars may not be the right. You protect the beta cells, protect the patient. And in the way, I protect the beta cells also. So now glucagon. There are number of studies that yes, DPP4, my friend has rightly said, glucagon, it lowers the glucagon level, it counters the glucagon levels, but at any HbA1c greater than 9, there are studies that DPP4 inhibitors are totally blunt and they cannot counteract the glucagon levels. Now, cost benefit ratio, I have already shown that they are equally cost effective and can be used. Now coming to infections, another point where my patient, my opponent, learned opponent was extremely obsessed, and we know that yes, I admit there are incidents of infections, but number one, they are usually of a single occurrence. They are not they do not cause fatality. So we are comparing simple non-hospitalizable infections to things which like decompensated heart failure, cardiovascular events. Okay, ketoacidosis, number of ketoacidosis were reported when we inadvertently used the SGLT2 inhibitors in type 1 diabetes patients. That is the problem. There are very few, and you know, nuclear power is a boon. People are there who have some other ideas, so you need to use. Just 1 second. Now, CVOT trials, my patient.
I'm sorry, your time's up. You have 2 minutes. Okay. So, Dr. Ayun, set the clock at 2 minutes, please.
Can I start? Okay. So many things already I have told, in SGLT inhibitor. First of all, limitations of those cardiovascular trials, because you have to keep it in mind whenever everything, like trial population, how the trial was done. So there are so many questions, and that I have already told. Second thing is that, yes, I am obsessed with beta cell function. That's, I think we all should be, because if you can improve beta cell function, the whole world is running behind that to have regeneration of the beta cells. Okay. So if you regenerate, can happen. Why are you letting patients to develop cardiovascular disease and all those things? Third thing is that you see which patients you are treating. For inhibitors definitely gives this age. Age over SGLT2 inhibitor. So I don't think that, and in this era of precision medicine, both the drugs absolutely holds good for different kinds of scenario. But when it comes to DPP4 inhibitor, particularly in Asian Indians, non-obese persons, definitely it has a role immediately after metformin. I don't think SGLT2 inhibitor comes there in terms of having a durable glycemic control and then this thing. Thank you.
So thank you to both the debaters. You have done a wonderful job. So as is customary, before the beginning of this debate, we had a show of hands from the audience where 1/3 spoke in favor of SGLT2 inhibitors, 1/3 spoke in favor of DPP4 inhibitors, or raised their hands rather in favor of DPP4 inhibitors. 1/3 were floating, sitting on the fence, possibly waiting for the debate to be over before forming an opinion. So let's see the results now. How many in the audience feel that it's for the motion, that they are in favor of what Dr. Shottam has spoken about, SGLT2 inhibitor rather than DPP4 inhibitor? Please raise your hands. So I think the same people, just a couple more. So how many are for inhibitor? So almost the same, possibly again a few more. So from the audience point of view, we have a hung result, but again in any academic debates, it's not one of the debaters who's a winner, it's science which is a winner. We should take the good and bad of both these molecules. We should form a balanced opinion. With the DPP4 inhibitors, we have a few strengths and almost no weakness to speak of. With SGLT2 inhibitors, we have several strengths and a few weaknesses to speak of. And there are some patients who are ideal candidates for either of these agents, but there are many patients who need both these agents together. So there's no enmity between them. So we should choose our patients, our drugs according to the patient that we are treating. On that note, I would like a big round of applause for both the debaters who have done a wonderful job.
Thank you.
And I would like to request Dr. Yeah, sir, please. Dr. Ayan and Dr. Shottam also on the dais, and Dr. Shomik sir to please felicitate both of them.
Thank you, everyone. That was indeed a great session over here, and everybody, I'm sure all of you have, enjoyed this session very much. So before we begin our next session, I have an announcement to make. All those, particularly PG students and others who are interested for participation in the quiz, you are requested to kindly enroll yourself at the registration desk or with Dr. Bodhayan, and we'll be having the prelims, written prelims section during the lunch hour in the hall. Please enroll yourself in the registration counter for the quiz session. With that, we move over to our next session, and we have a very exciting session coming up. For that, I would like to call up on stage our chairpersons, Dr. D.P. Ghatak, who is a senior physician from Durgapur. Sir, please come on the dais, please. Also, Dr. Rakesh Kumar, who is a consultant diabetologist from Durgapur. And I would like to request chairpersons to introduce the speakers for the session. Thank you.
Next section will be on the case discussion. It will be delivered by the Dr. Vikram Chauhan. I request Dr. Vikram Chauhan to please join us and enlighten us with your talk. Thank you, sir. And Dr. Vikram Chauhan is a very famous and renowned speaker with a very long CV. So I would not read out of the CV to waste time because we are already running short of. Please proceed.
Thank you very much to the chairperson for the kind introduction. Glad to be back in Bengal. Before my DM, I had the privilege of being at SSKM Hospital as an observer at the time. And Professor Shankar Chaudhary was, of course, the HOD at the time. So privileged to have him here after seeing him after so many years. Thank you also to the Bdcon committee for having invited me. Is on a 65-year-old man with type 2 diabetes on 40 milligrams a day, and the lipid profile, as is often the case in our population, continues to be unsatisfactory, with cholesterol total at 280 milligrams per deciliter, triglyceride at 310, VLDL 62, HDL 44, and LDL 174. What next should we do? Professor Eugene Grunwald is the author of the textbook that bears his name, the cardiology textbook, and this is from him. Cholesterol, the the race to the bottom. So there's evidence that low levels of LDLC, which is less than 0.5 millimole per liter, and even ultra low level less than 0.3 are well tolerated and safe as per published literature. And in secondary prevention trials, these low levels might be more effective in reducing major adverse cardiovascular events than the current guideline targets of around 1.8 and 1.4 for high risk and very high risk patients respectively. So it would be desirable and safe to conduct a prospective randomized trial to compare the clinical effectiveness at 3 target levels, which are even lower than what the current guidelines state. So 1.4, 0.9 and 0.4 millimole per liter. And if you see trials which have evaluated different molecules and the reduction in LDL, there is a progressive decline in the levels that have been achieved recently. And the postulation is that CVD events should improve concurrently. So the European Society for Cardiology, along with the European Atherosclerosis Society in 2019, issued their guidelines for management of dyslipidemias. And the focus was, as always, on a more intensive reduction of LDLC across the risk categories of CV, of cardiovascular disease. So for secondary prevention in very high risk patients, an LDL reduction of more than 50% from baseline and LDL goal of less than 55 milligram per deciliter is recommended. And for patients with atherosclerotic cardiovascular disease who experience vascular event within 2 years while taking tolerated statin, an LDL goal of less than 40 may be considered. So we are going down, as time progresses with what guidelines are recommending at least. So these are the guidelines, and if the score so as per all guidelines, as the risk calculator, you have to see where the patient fits in your risk calculator. If the patient is at low risk, so the risk being at less than 1%, then the treatment goal is, then the target should be around 116. If the patient is at moderate risk, as per the ESC calculator, which is young patients with type 2, type 1 diabetes less than 35, type 2 less than 50, and a diabetes duration less than 10 years without other risk factors, then the patient is at moderate risk, and the target should be 100 milligram per deciliter or lesser. If the patient is at high risk, so a score of more than 5 to 10%, then the target stands at 70. And if the patient is very high risk, so the presence of pre-existing atherosclerotic cardiovascular disease with familial hypercholesterolemia, with ASCVD or other major risk factors, severe CKD, diabetes, and target organ damage of more than 3 major risk factors, then the target should be 55 milligram per deciliter or lesser, and alongside that, more than 50% reduction from the baseline should be aimed for. But we know that for all these LDL targets, we still have a residual risk, which is clearly not explained. And the way to explain that and potentially intervene might be that for the residual cholesterol risk that remains, you further reduce LDL. For the inflammatory risk that remains, you target inflammation. The triglyceride in itself forms a risk factor, so you target that. And there is a residual thrombotic risk also, so you have to analyze if there is a procoagulant state that is also not helping the patient's cause. Now, suboptimal cholesterol response to initiation of statins. This is an article published in 2019, and it says that optimal lowering of LDL-C is not achieved within 2 years in over half of the patients in general population who are initiated on statins, and these will consequently have an increased risk of future cardiovascular disease. Now, in a database analysis, they found that patients who initially received statin monotherapy, which was then titrated to either a higher dose or switched to another high potency dose of another statin, continued to elude the target by around 30 to 40%, even after up-titrating the statins. And the target here was 100 milligram per deciliter. So these are the drugs that we have currently with approval. So statins, of course, are the gold standard, the best, the most evaluated drugs that we have as of now, with an LDL reduction efficacy of around 30 to 50%, and event reduction rate that has been demonstrated, and they are obviously approved for the purpose. Ezetimibe adds on to a further 15 to 20% reduction of LDL, and is approved for introduction alongside statins. Then the new PCSK9 inhibitors, which are of course extremely expensive and also injectable. Another small issue with them, do bring about a robust LDL reduction of 50 to 60% and approved for event reduction alongside statins. And bempedoic acid, which has recently come onto the Indian market, brings about an LDL reduction of 17 to 25%, and the outcome trial for event reduction is currently in progress. So this is where the drugs are acting a very broad slide. So bempedoic acid acts at the ATP citrate lyase level, inhibits that, and inhibits the resultant intermediates along the way to cholesterol production. The levels of cholesterol alongside the intermediates come down because you have reduced cholesterol availability. So there's an upregulation of LDL receptors, and that brings down that basically mops up the LDL that is present in circulation. So statins, as we know, are HMG-CoA reductive inhibitors. Again, after this step of statin inhibition, there are still a number of intermediates that are also reduced. And the significance of that, I won't talk about that here. If there's time in the discussion, then we can talk about that. PCSK9 inhibitors, so one of them has been approved in India, very expensive. And these, of course, they inhibit PCSK, which is involved in recycling the LDL receptor. So the LDL receptor basically stays for a longer period of time, mops up more LDL, and brings about its effect. Inclisiran is a small interfering RNA of the PCSK9 enzyme, and this is how it brings about its inhibition of PCSK levels, PCSK inhibitor levels. Ezetimibe, as I'll just come to ezetimibe. So this is an NPC1L1 receptor inhibitor. It inhibits the protein, reduces absorption at the level of the small intestine, approved by the FDA as diet adjunct for reducing TC, LDL, ApoB, and non-HDL in patients having primary hyperlipidemia, either alone or alongside statin therapy. Also for the same indications in patients having mixed hyperlipidemia, along with fenofibrate also. In patients with homozygous familial hypercholesterolemia alongside statins, and in the condition of phytosterolemia. Dose being 10 milligram once a day with or without food, brings about, as I mentioned, in monotherapy, 18% reduction of LDL, and in combination, 25% reduction. So the inhibition of cholesterol here is at the level of the jejunal enterocyte brush border, and the protein is, of course, Niemann-Pick C1P1. 16 to 24% reduction, as I mentioned. But the absolute reduction primary events is comes to around 2%, which is much less than what you would expect given the LDL reduction. These are landmark trials for ezetimibe. The SEAS trial found that a combination of ezetimibe and simvastatin did not reduce MACE. SHARP showed that the combination did reduce MACE, and IMPROVE IT, which was the most recent trial, showed that the combination of ezetimibe and simvastatin did have a significantly lower risk of MACE as a consequence. Again, findings that in diabetes, there is a higher expression of the NPC1L1 gene. So this should be more effective in diabetes as a consequence. That is the postulation. This was an intravascular ultrasound study that showed that there was a substantial reduction in blood when you had patients on atorvastatin and ezetimibe compared to those who were on atorvastatin alone. Now, PCSK9 monoclonal antibodies are alirocumab and evolocumab. The mechanism being they are monoclonal antibodies to the PCSK9 molecule, and they bind with PCSK9, increase the number of LDL receptors, and that clears up the circulating LDL-C. Approved by the FDA to reduce LDL in primary hyperlipidemia. Alirocumab is indicated to reduce the risk of MI, stroke, and unstable angina requiring hospitalization with ASCVD patients. Evolocumab again is approved by FDA for reducing MI, stroke, coronary vascularization in patients with ASCVD, and also in pediatric patients having heterozygous familial hypercholesterolemia as diet adjunct. The mean LDL reduction with alirocumab, in addition to maximally tolerated statin, comes to 45 to 58%, and in the case of evolocumab, comes to 64 to 58%. So these are the landmark trials for PCSK9 inhibitors. Odyssey showed that MACE was significantly reduced in alirocumab compared to placebo. Relative risk reduction not that great as far as MACE was concerned, it was 15%. Mendel 2 showed that the reduction in LDLC was 55 to 57% compared to placebo. GWAS 2 showed that LDL reduced by 53 to 56%. Descartes showed a reduction in LDL by 57%. And Fourier, which was the most recent, showed that the MACE reduction was 9.8% with evolocumab and only and 11.3% with placebo. So the absolute numbers actually in terms of hard clinical endpoints are much lesser than the surrogate endpoints of LDL-C reduction. Bempedoic acid, an ATP citrate lyase inhibitor, inhibits cholesterol synthesis in the liver, increases LDL receptor density. And importantly, its active metabolite requires coenzyme A activation, which is expressed primarily in the liver. So there is, at least in theory, a lesser possibility of target effects because of the primary expression of that co-activating enzyme required present in the liver. Approved by the FDA for LDL reduction in ASCVD and heterozygous familial hypercholesterolemia as diet adjunct and maximally tolerated statin, 180 milligrams once daily with or without food. And the reduction that you get comes to around 18% alongside statins. Landmark trials for bempedoic acid. Harmony showed that LDL reduction was around 17% at week 12. Wisdom, Serenity, and Tranquility again showed LDL-C reduction. The outcomes trial is awaited. This again shows that on top of statins, it was significantly effective in reducing LDL in those who were statin intolerant. Inclisiran is a small interfering RNA, so a unique mechanism of action targeting PCSK9. It inhibits PCSK9 production in the liver, and that prolongs the activity of the LDL receptor. So the more LDL receptors you have, the more of it is there to mop up the LDL-C that is in the circulation. Approved by the US FDA for decreasing LDL-C in patients with ASCVD and heterozygous familial hypercholesterolemia as diet adjunct and maximally tolerated statin. Administered as subcutaneous injection on day 190 and every 6 monthly. And the reduction in LDL comes to around 50%. Landmark trials, Orion 10 and 11 showed an LDL reduction by 51 and 40 and 50 and 46%. Orion 3 and Orion 4 and 8 are ongoing. And 4 will look at the hard clinical endpoints as well. So a diagrammatic representation of how they act. There are others also along like volanersosen, which targets ApoC3, and also evanucumab, which targets ANGPTL3. Old groups of drugs are bile acid sequestrants, add-on therapy to a maximally tolerated statin for achieving greater LDL reduction in patients not having hypertriglyceridemia. The advantages that you get a simultaneous reduction of glucose alongside and reduction in LDL by 25%, slight increase in HDL, a reduced CV mortality, but the cons are GI side effects. You cannot give in patients having hypertriglyceridemia. Right? There are drug interactions that are known, and they absorb and they affect the absorption of fat-soluble vitamins. Nicotinic acid is again an old drug, reduced elevated total cholesterol, LDL-C, ApoB, triglycerides, and increased the HDL-C in patients having primary hyperlipidemia and mixed dyslipidemia. Increases HDL and is recommended for patients with severe hypertriglyceridemia. But the con is that there are frequent adverse drug reactions which are very distressing, and there is bile interaction along with bile acid sequestrants, and therefore they need to be used with caution for this purpose. Fibrates are in use alongside statins, as we know, used as an adjunct to dietary modifications in adults having primary hyperlipidemia, mixed dyslipidemia, or on patients having severe hypertriglyceridemia. The advantage is that they are oral and bring about an additional LDL-C reduction alongside the TG reduction, but they may cause a derangement in AST-ALT levels and infrequent elevations in CPK. Dose reduction required if the patient has renal insufficiency. icosapent ethyl was tested in a Japanese trial. So we know that the whole thing of omega-3 fatty acids being useful has been in the in theory, and this was where it was tested. So an ethyl ester of icosapentaenoic acid, it is an adjunct therapy to maximally tolerated statin to reduce the risk of CV events among adults with elevated TG and established CVD or diabetes, and 2 additional risk factors for CVD. And the dose is mentioned here. The advantage is that you reduce CV risk among patients with elevated TG as an add-on therapy, but the problem is that there is a slight increase in atrial fibrillation risk, and this was also limited to patients with pre-existing fibrillation only. Also, a slight increase in risk in bleeding in patients on antithrombotic. So this is how dyslipidemia is evolving. So we've moved on from an oral combination daily to the monoclonal antibodies monthly or bi-monthly, then the more complicated antisense oligonucleotides weekly or monthly, to the small interfering RNA biannually, vaccination possibly annually, and perhaps gene editing for which would take care of the LDL for life. And there are other targets which are being looked at. So non-HDL and lipoprotein A, which is the new target for the newer groups of drugs like pelacarsen. A suggested algorithm. So you do an CV risk assessment using whatever calculator that you are familiar with. If the baseline LDL-C levels suggest that there is an indication for drug therapy, then you define the treatment goal as per the risk that the patient falls in. Use the hypotensive statin at the highest recommended tolerable dose to reach the goal. If it is reached, then you follow up annually or more frequently if indicated. Or if the goal is not achieved, you add ezetimibe. If still not achieved, you consider adding PCSK9 inhibitor or and of course, how often should lipids be tested? A frequent question that comes up. So 2 to 3 months until the 1 to 2 months until the goal is achieved. And if the patient has had recent acute coronary syndrome, then check after 1 to 2 months. The Lipid Association of India looks different, but tends to mirror these guidelines. So the target LDL-C is 50, less than 50 in patients who are very high risk or extreme high risk to achieve LDL cholesterol goals. With that, I come to the end of what I had to say. There are some other things that I think we can discuss if there is time in the discussion. I hand over the control back to the.
Thank you, Chauhan sir, for such a nice deliberation. We may take questions at the end of the session. So you may take your seat, please. So next talk is going to be on our favorite molecule without which the diabetes patients are incomplete in Indian setting. And to speak on that favorite molecule, I would like to invite our favorite Dr. K.K. Gangopadhyay sir from Calcutta. He needs no introduction. He is a very renowned endocrinologist at Calcutta. Sir, over to you, sir, please.
Thank you for your kind words, Chairperson, sir. So when I was first given this topic, আমি ভাবলাম যে কি বলবো, এটা তো আপনারা সবাই জানেনই সালফোনিলিয়া ব্যাপারে, এতদিন ধরে আমরা সব জেনে আসছি। So what more in 2022? So I put together a few of the data যেটা 30 বছর আগে। So I passed out in 1990. So তখন আমি কি করতাম আর এখন আমি কি করছি, that I will put. So that will make it a little bit interesting. So the agenda will not follow in this order. So basically efficacy, beta cell exhaustion, কারণ নতুন মলিকিউল এলেই আগে সালফোনিলিয়া বিটা সেল এক্সস্ট করছে, খারাপ খারাপ খারাপ। সিবি সেফটি, সালফোনিলিয়া সিবি সেফটি সেফ নয়। হাইপোগ্লাইসিমিয়া ট্রু, weight gain, Caucasian, yes, Indian scenario it is not that much of a problem. Few cases yes, but majority no. So প্রেজেন্টেশনের মধ্যে এগুলো ইনকর্পোরেটেড থাকবে। So first thing is, in the light of CVOTs, we sometimes lose vision of the fact যে এই CVOT গুলো আমরা যে পেশেন্ট গুলো দেখি সেগুলোকে রিফ্লেক্ট করে না। So this is one discover study of about 16,000 patients, এদেরকে নিয়ে দেখা হলো যে এই সিভিওটি আমরা করছি এতগুলো, কত পার্সেন্ট আমাদের যে পেশেন্ট গুলো, আজকে যে আমার আউটডোরে 100টা পেশেন্ট আছে, কজন এই সিভিওটির ক্রাইটেরিয়া ফুলফিল করবে। সো ইফ ইউ সি হিয়ার, look at the Asia Pacific, which is second here. So canvas 19%, declared TIMI সবচেয়ে বেশি, which is around 35%, Empire Age 4.7, Vertis CB 4.7. So majority 60 থেকে 90% of the patient এই সিভিওটির মধ্যে কাভার্ড নেই, কিন্তু আমরা ওই ডেটাটাকে এক্সট্রাপোলেট করে করছি। আমাদের মেইন এম হলো গিয়ে সুগারটা কমানো ফার্স্ট, তারপরে অফকোর্স উই শুড লুক, অ্যাজ সত্যম সেড, লুক অ্যাট দ্য পেশেন্ট, তো ব্লাড প্রেশার, সিভি রিস্ক ফ্যাক্টর, সিকেডি, ওগুলো তো দেখতে হবেই। কিন্তু পেশেন্ট যদি আসে সুগার নিয়ে, আর যদি সুগার আপনি না কমাতে পারেন, তাহলে রেস্ট এশিওরড উইল নট কাম টু ইউ। ও 10 বছর পরে হার্ট অ্যাটাক কমলো কিনা সেটার জন্য আপনার কাছে আসবে না। So I'll give some hypothetical cases. So 1990 when I passed out, and 2022 now. So একটা 50-year-old tiredness নিয়ে, blood sugar 150 to 48.1, এটা আমার ছবি 30 বছর আগের। I can myself I cannot recognize it. এখন সাইজটা জাস্ট ডাবলের একটু বেশি। সো ডায়েট যদি কাউকে দিতে হয় আমাকেই দেওয়া উচিত। সো 1990-তে যদি এই পেশেন্টটা আসতো, তখন কি ছিল? মেটফরমিন, গ্লিবেনক্লামাইড, ইনসুলিন, আর কিছু ছিল না। তো আর তখন এত অ্যাগ্রেসিভ ট্রিটমেন্ট নয়, তখন হলো গিয়ে দেখি না একটু, হ্যাঁ ডায়েট এক্সারসাইজ, হ্যাঁ করুন, দেখি না। তো তখন হয়তো আমি ডায়েট তো দিতাম, মেটফরমিন বোধহয় দিতাম, তারপরে এই দেখি না একটু, আসুন 3 মাস পরে দেখি। এখনো তো কোনো এভিডেন্স নেই যে তাড়াতাড়ি কমিয়ে কিছু লাভ হচ্ছে না, সেটা এভিডেন্স তো নেই। তো এখন এটা আমার মোটা চেহারা, 2022, নাও I will be more aggressive. I might give metformin, I might give either DPP for SGLT2 or pioglitazone depending on the BMI. আমি এগুলো অ্যাড করব। Some cases I might think about low dose sulfia, কিন্তু HbA1c 8.1 সালফিনিল এখানে না দিলেও চলবে, এইগুলো দিয়েই কাজ হয়ে যাবে উইদাউট হাইপোগ্লাইসিমিয়া। সালফিনিল দিলে কমবে তো বটে, কিন্তু হাইপোগ্লাইসিমিয়া হিট আর্লি। So this is the motto. কেন হিট আর্লি? কোনো এভিডেন্স আছে? So this is very nicely demonstrated by Rudy Holman's model, UKPDS থেকে derive করা। তো বললো যে একটা 50-year-old male newly diagnosed, HbA1c 8% নিয়ে এলো, আপনি ফেলে রাখলেন 8 বছর,
comes less than 25, 30 in 7 days time. So if you start, you give Repatha injection, in next week you will get 25. Yeah. Yes, sir. Recurrent events, familial hypercholesterolemia and recurrent events. Even if the patient has dual antiplatelet, 14 rosuvastatin, still he is having recurrent events, you have to. You see LED infarcted, RC infarcted, every time he comes again. So these are patients.
We don't allow any, we will not allow any further questions. So back to you, Subham.
Now I would like to person our speakers. Dr. Ghotok, kindly felicitate Dr. Bikram Chauhan, please. And now request Dr. Rakesh Kumar to kindly felicitate Dr. Gangopadhyay, sir, please. On behalf of BDF, now on behalf of BDF, I would like to felicitate Dr. Shomik Goswami to our chairpersons, Dr. Rakesh Kumar and Dr. Ghotok, please.
So it is now finally time for one of the most anticipated sessions of this year's Bdcon, the prestigious Dr. APJ Abdul Kalam oration. To conduct the proceedings for the oration, I would request two key members of this year's organizing committee to kindly come up on the dais. I would request Professor Shamul Kundu, the organizing chairman of Bdcon 2022, to kindly come up on the dais. And I would also request Dr. Amitabh Biswas, the organizing secretary of Bdcon 2022, to come up. This year, the prestigious Dr. APJ Abdul Kalam oration has been awarded to none other than Professor Shubhankar Choudhury, our very own teacher, a very respected endocrinologist. So I would request Professor Choudhury to kindly come up and take his position in the center of the dais. I request Dr. Amitabh Biswas to read out the citation for Abdul Kalam oration.
Welcome you all for this APJ Abdul Kalam oration this year. This prestigious oration has been named after Bharat Ratna APJ Abdul Kalam, the inspiring Indian aerospace scientist who ignited numerous minds and also served as the 11th President of India. This year, Bengal Diabetes Foundation is privileged and proud to confer the APJ Abdul Kalam oration to Professor Shubhankar Choudhury. He is an endocrinologist par excellence with top-cited publications who has trained numerous students across India in the art and science of endocrinology. Professor Choudhury is a towering figure and a pioneer in India who presently heads the Department of Endocrinology at PGIMER, Chandigarh.
I think it would be
IPGIMER. Okay.
So I request Professor Shamul Kundu to felicitate our orator for this year with the customary medal and so over to the chairpersons to conduct the rest of the proceedings.
Without wasting much time, I request Professor Chaudhary to start the resolution.
Thank you very much. I'm humbled by this gesture. We all know about APJ Abdul Kalam. I think two descriptions of this man. One is the people's president, and the other, I think, is the missile man of India, are very appropriate. Now, in the course, and I stand between you and lunch, and we have had an excellent, exhaustive session from the morning. So I'll try and wrap up as soon as. The attempt here will be to have one view of management of hyperglycemia in type 2 diabetes with a critical look at different guidelines, including the evidence on which these guidelines are based, provide some reality check, and then, of course, some suggestion as to how we can take things forward. So I do know that this gentleman, Paracelsus, made this statement in the 16th century, early 16th century. And today science has come a long way. But nonetheless, I think still management of a disease like type 2 diabetes, a lifelong disease, is very much an art. It's not just science. This is something that we all need to remember. We also are aware that around 1550 BC, we probably have the earliest reference to a disease which is likely diabetes that was being talked about in the Ebers papyrus in Egypt. However, if we look at the treatment for this condition, probably it was only about 100 years back with the discovery of insulin that we brought science into the treatment of this condition. And today, of course, we are fortunate to have so many classes of drugs. If we leave aside the different types of insulin that are shown here, we have so many different non-insulin treatment, 6, 7, 8, in fact, 9 different classes of drugs which are available to us for treatment of type 2 diabetes. So we should actually, we are spoiled for choice in a sense, and then we should therefore be achieving glycemic control in most of our patients. But what is the reality? And if you look close to home, in our own country, we have this ICMR in DIAB study, and I have been fortunate to be the principal investigator for the West Bengal arm of this study. We find that about 2/3 of our patients do not reach or maintain A1C target if we keep it at less than 7%. So vast majority, despite the availability of so many drugs, do not reach targets, and there are different reasons, of course. DPP-4 inhibitors, which are relatively affordable. So whatever we see in the international guidelines may not directly be applicable to our use. We have to use our judgment as well. And the other issue, I mean, this is not meant to put you off. I know most of us chose medicine because we didn't like mathematics, but it's just to drive home the point that when we look at study results, and as a pharma industry nowadays that makes us look at so many study results, and we remember the EMPA-REG study, the earth-shattering study, the first study sort of, which showed that an anti-diabetic agent reduces cardiovascular events and importantly reduces death. We now just concentrate on reduction in 2022. First of all, greater awareness with so many CMEs happening, diabetes, and so many physicians becoming more conscious, alert, and also the public media carrying messages of diabetes. The diagnosis of diabetes type 2 may also be occurring much earlier these days. And similarly, whether we can extrapolate this figure straight away, because we are treating these individuals. We have now got newer agents, glitazones and other agents, SGLT2, DPP4, so on and so forth. Whether we are not altering the course of the disease is also something that we need to consider. So it does not become axiomatic that after a certain number of years, every person with type 2 diabetes will require insulin. And let us also remember that administration of insulin from outside is not the same as endogenous adequate provision of insulin, because you need to have adequate amounts of insulin at the level of the liver, which is the important target organs. You need to have peripheral hyperinsulinemia levels of insulin at the liver level, because we that so therefore numbers require insulin. Even in this shown in the curve continues also. The final answer is what I try to drive up, and the fact that it is not much different between insulin and sulfonylurea. So let's get that clear. And then so much about science. As I had indicated at the very beginning, there is a lot of art to go into the treatment of type 2 diabetes. And here we capture some of these issues as enunciated by August bodies, the ADA, ESD guidelines. So you have to consider individual priorities, current lifestyle, health behaviors. You have to look at emotional well-being. You have to individualize, and so on and so forth. So it's very, very important that treatment also fail. So that's also something that we need to understand. And uncontrolled temporal hyperglycemia, for example, we all see patients losing their HbA1cs or having spiked HbA1cs if they come in maybe October, November. And then again, maybe when they come back in March, maybe the HbA1cs are better. We all know the festive season, the sweets and all that. So we should not decide on failure just maybe one value of A1C. We have to see the trend. We have to understand what's going underneath A1C value. And now can I quickly so any figures, anyone 20, the same for insulin, right? Good. So rather than 90%, we got 40%. And now I'll share quick data which is unpublished as yet. My personal experience looked at about 1,000 patients data in the last one and a half years in type 2 diabetes, whatever the way that I diagnosed them as type 2, who has had duration, known duration more than 10 years, who has been on my follow-up at least for 6 months and at least 2 consultations, so that I have time to maybe adjust doses and get reasonable results. And what I found that if you look further down, the duration on those on insulin, the mean duration was higher, about 22 years, compared to non-insulin is about 16.5 years. BMI is in those on insulin. Intuitively, we feel that the ones who are insulin deficient are leaner, but on insulin in my 1,000 patients with type 2 diabetes had high BMI. Whether it's an effect of the insulin itself causing the weight, we cannot say for such. This study will not be able to tell us. Number of oral agents, I actually do use 3, 4, 5 types of oral agents. I don't mind so far, so long there are no side effects and so long we have the patients coming to for follow-up. Not indefinitely, we keep them on a large amounts of oral agents. And we find that the mean number of types of oral agents was 3.3 in those who are not on insulin. And in those on insulin, they were still on significant number of oral agents. I tend to continue the metformin, but often I tend to continue if they have been on a DPP-4 inhibitor, SGLT2 inhibitor, they tend to continue. Sulfonylureas, I do stop if the patient is on anything beyond basal insulin only. If it pre-makes it's multiple cutaneous insulin injection, then of course I stop the sulfonylurea. And diabetes kidney stage based on the eGFR, again they are similar, about stage 2 CKD or DKD in most of the cases. And the important point that I wish to point out is the A1C level. If you look in those on insulin versus those not on insulin in type 2 diabetes, more than 10 years known duration, the A1C is actually worse in those on insulin than in those on non-insulin treatment. Now, I request all of you actually to look back into your records if you have any. This is not to say that insulin is bad, insulin is wrong, but possibly, I mean, there could be 2 reasons. Difficult to control. The other would be the real issues in relation to the uncertainties of the action of insulin, which leads us possibly to use suboptimal doses of insulin in many individuals. So with this, I would like to come to the last part of our talk. when we look at guidelines, mostly we are taught as to how to up-titrate, how to intensify your treatment. Please do remember there is also an inertia because of which we do not de-intensify treatment. There are individuals who may well intensify, who are on insulin, who may be taken off insulin. Not all of them, some of them. Maybe someone had been started because he was admitted with a stroke or a severe infection or for a surgery. And somehow that insulin is still continuing. So we need to look back as to the indication for the start of insulin and therefore adjust treatment accordingly. And treatment de-intensification is uncommon in adults with type 2 diabetes. And if you look at the ACCORD study, it was found that among frail patients or those with multiple comorbidities, over 3/4 with low HbA1c did not have the glycemic therapy de-intensified even after safety concerns were raised. Who knows whether this was the cause for the higher mortality that we in the intensively treated arm in the ACCORD study. And this again, looking at about 76,000 older adults with type 2 diabetes who were admitted or had to reach hospital emergency because of hypoglycemia, and who are on sulfonylurea or insulin, at least 50% did not have their doses down titrated even after hospital visit because of hypoglycemia. So where are we heading? Well, possibly we are heading an era of artificial intelligence. Maybe we are heading to an era where the young generation, the Showmix, the Deeps, and all the others would be taking over. We have all our documents, all our information stored in cloud, what we're eating, what we are speaking, what we are walking, and there will be possibly integration of these data, and then you have possibly the best possible outcome to provide rational treatment for our people with type 2 diabetes. So with this word, I would like to wind up and thank once again the organizers for the wonderful opportunity provided to me. And I also, just a second, please. I also wish to fondly remember Dr. Sushobhan Banerjee, who has been associated with this organization for so many years. I could not attend some of the programs when he had very dearly invited me to Shantiniketan. I could not, so I hope his soul rests in peace. Thank you very much.
Thank you, sir. Thank you, Professor Chaudhary. This is the oration, so there is no question and answer. So we'll proceed for the lunch and we'll be back to the hall by 2:30 for the next sessions. One declaration that Bengal Diabetes Foundation is observing World Diabetes Day on 14th of November. It will be in Benacity, the Chamber of Commerce, and there we will have a check and a walk-on for 3 kilometers, followed by checks of the lipid profile, by HbA1c, eye checkup, advice, request, send your patients and other relatives to attend it. Thank you.
Thank you, everybody. We'll now take a short break for lunch and we'll accumulate one. I request all the delegates to go and have the lunch, which is just arranged outside. And please come back by 2:45. All participants in the quiz contest, I would like to request all of you to please stay in the hall. We'll be having the prelims of written prelims of the quiz contest right here in the hall during the lunch time. So I'll request all the quiz contestants to please stay in the hall.
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior, beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
কুইজে আছে আচ্ছা আমি কি নামগুলো একটু বলে ফেলছি অমিত কুমার সিং অন্বেষা সৌরভ ওকে এন্ড অপূর্ব ডক্টর অপূর্ব ওকে ডক্টর অর্ণব ইউ আর হিয়ার গ্রেট এন্ড অশ্বিনী কুমার পান্ডা yes you are here Atul Pradhan and Nildeep Kumar Panigrahi okay and Raghul B you are here Rajiv Kumar and Shreya Roy, Shomodeep Dash, Suryakant Maurya, yes. Nepal, Debadita, Anupam Roy, they have gone for lunch. Okay, we'll wait for some time for them and this will be a written prelims round. You are yet to have lunch. Okay, so this will just take a few minutes of your time. Yeah, please have your seat. We have got 15 questions, okay? Most of them are, all of them are actually MCQ ones. This is the prelims round. Once you fill it back, you're gonna go for lunch, okay? And do you have, any of you have the poster presentation over here? 2 poster presentations are there, na? Okay, after this quiz, you'll be having lunch and then we'll have the poster sessions over there, okay? Just by the pool side.
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior, beyond glycemic control is recommended.
So for the quiz, we'll have the written prelims and
diabetes.
15 questions are there to be answered in 10 minutes. So we'll make 2 in each group. So we'll be having already, I've got 16 names with me. So I'll be having 8 teams, right? So you can pair together by 2 and we'll be having 8 teams and we have to sit sufficiently apart. So that goes without saying. Yeah. Yeah, on pair only. The written we will give, 8 teams. We'll give 8 sets of questions. We will answer in MCQs, and we'll be having the final rounds later on. Final is post lunch. This is only prelims. You'll just take 10 minutes. Sorry, I didn't get you. I'll just. I'm having 16 names, but somebody is not present here, I think. So we have got an odd number. No, he is not allowed. Okay, he is chief advisor or whatever. I'll just call up your name one again. I don't know who is absent. Amit Kumar Singh, you are present. No. Okay. Anesha Shorab, present. Apurv, Dr. present. Dr. Arnav, you are also present. Dr. Ashini Kumar Panda, yes, you are present. Dr. Atul Pradhan, Nildeep, yes, Raghul B, Rajiv Kumar, and Shreya, Shomodeep, Suryakant, you are present. Nepal Shaw is absent. Okay, Devaditya Shaha, no. Anupam Roy, Ria, you are present. You know these guys, Nepal Shaw, Anupam Roy, and Devaditya Shaha. You have know them.
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance, fast prandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior, beyond glycemic control is recommended. Diabetes mellitus, pre-diabetes, and diabesity.
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior, beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior, beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior, beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
Neeraj, Salma, you two will team together, no? Take a separate seat. Matlab two will together. Hey, you can sit over here also. You have to pair up with somebody else because we are having two in each group. Okay. So, Dr. Biswaranjan, you will pair up with Dr. D.R. Roy. Up. You will pair up. He already has a team. So, for the time, let them all three be together. Yes. So, there will be an exception.
Cresvin Beta helps in the prevention and remission
कितने
of
लोग हैं?
diabetes.
तुम्हारा नाम क्या है?
Cresvin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c.
Ruled out.
Cresvin
He is
Beta,
part of the
the beta cell savior, beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
I'll just summarize for the time. Group A, Dr. Rajiv Kumar and Dr. Suryakant. Right. Group B, Dr. Apuv and Dr. Nildeep. Yeah. And Group C, Dr. Amit Kumar Singh and Dr. Annesa. Right. Group D, Dr. Arnav and Dr. Raghul B. Yeah. And Group E, this is an exception. We have a 3-member group since we cannot find a partner. So Dr. Shreya Roy, Dr. Shomadip Dash and Dr. Riya Roy. You are Group E. And Group F, Dr. Ashwini Kumar Panda and Dr. Atul Pradhan. And G is Dr. Devaditya Shaha and Dr. Shobhik Das. You are there, right. And Group H, Dr. Anupam and Dr. Nepal Shaw. Yeah. Group I, Dr. Neeraj Singh and Dr. Sharma Biswas. You are? Where are you? Here. You are Group I, Neeraj. Group I. And finally, Group J, Dr. Vishwaranjan Shamal and Dr. Somnath Banerjee. Right? Okay, so first of all, give them a big round of applause. Last,
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta.
So we'll be having a 10 minutes timer.
Fasting blood
and
glucose.
I'll be giving you
postprandial blood glucose.
Yes,
and
each sheet,
HbA1c. Cresvin Beta. The
15
beta cell
questions
savior.
in each sheet.
Beyond
You have to
glycemic
mark the
control
correct
is
answer.
recommended
There is no negative
in type
point
2
for
diabetes mellitus,
any wrong
prediabetes,
answer.
and
You have to
diabesity.
finish that by 10 minutes. First, I will request you, I'll not start the timer now. I'll request you to write your group and your name on the top of the sheet. Okay? Please write your group in each sheet. Okay. No, please write your groups in each sheet, on the back of each sheet. Okay.
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior, beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
Please write your groups in each sheet. All of you got the papers? Right. Okay. So we have got 15 questions, 10 minutes. Timer starts now. Yeah, timer is right there on the screen. Please finish by 10 minutes and we'll collect the sheets as soon as possible. If you have finished early, you can let me know. I'll collect earlier. Dr. Anshuman, please. Please, please, please.
Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior, beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity. It seems the questions are quite easy.
judging by your looks. And just to motivate you more, there is attractive prizes at the end of final round. This is just a prelims. There is no negative marking, so tick your options vigorously. Little over 4 minutes left. If you are finished, you can submit.
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance, fasting blood glucose, postprandial blood glucose, and HbA1c. Cresvin Beta, the beta cell savior beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes, and diabesity.
Cresvin Beta helps in the prevention and remission of diabetes.
Those who have finished,
Beta reduces insulin resistance, fasting blood
noted
glucose,
your, group name?
postprandial blood glucose. Cresvin Beta, the beta cell savior, beyond glycemic control is recommended in type 2
Okay, time is over.
diabetes
Please submit, everybody.
mellitus, pre-diabetes and diabesity.
And all participants, if you have lunch, to vote for lunch. And post your lunch, those who have submitted poster, just stay by your poster. And we'll be having the poster competition over there. And we'll be having the final. The poster has been okay. The poster has been already been seen by the judges, and we'll be having the results later on. And after this session, we'll be having so thank you, participants. I request delegates present over here also to give them a big round of applause. So, simply because of their effort and because of their enthusiasm, and I wish all of you best of luck.
Cresvin Beta helps in the prevention and remission of diabetes.
Cresvin Beta reduces insulin resistance,
Fasting blood glucose,
postprandial blood glucose, and HbA1c. Cresvin Beta, the beta savior, beyond glycemic control is recommended in type 2 diabetes mellitus, pre-diabetes and diabesity.
So we will start our final session for today's evening. So today we will start the final session. I request all the delegates and all the members to come to the auditorium hall so that we can start our session. Because we are already running late. And I will request the chairpersons and speakers to get ready for the final session.
Cresswin Beta helps in the prevention and remission of diabetes.
Cresswin Beta reduces insulin resistance,
Fasting blood glucose,
postprandial blood glucose, and HbA1c. Cresswin Beta, the beta cell savior beyond glycemic control, is recommended in type 2 diabetes mellitus, pre-diabetes.
So we are all set for today's final session. Chairpersons and speakers are all ready. So I will request the chairperson to come to the dais. So I request Dr. Arunangsu Ganguly, Dr. Sastinarayan Chakraborty, and Dr. Rajay Lui to come to the dais, please, sir. So Dr. Arunangsu Ganguly is Chairman, Health World Hospital, Durgapur, Senior Consultant, Interventional Cardiologist. Dr. Sastinarayan Chakraborty is Consultant Diabetologist, practicing at Durgapur. And Dr. Rajan Palu is Senior Consultant, Endocrinologist at Mission Hospital, Durgapur. So without much of delay, we will start our session. I hand over the session to the chairpersons. They will introduce the speakers. So over to you, sir.
Good evening, everyone. It is a pleasure to invite Dr. J.J. Mukherjee, sir, for the first talk on beta cell prevention, the backbone of type 2 diabetes management. Professor J.J. Mukherjee, sir, doesn't need a separate introduction. Sir is working as a senior consultant endocrinologist, and sir is in Apollo Clinical Hospital. Sir is a section editor of the Diabetes, associated editor in the prestigious Journal of Neuroendocrinology. Over to you, sir.
Thank you. Good afternoon. 4 things are stacked against this talk. First, India is thankfully survived. We were 98 for 3, and now I just saw 165 for 4. Last over is still being played. Second thing, it's a very complex and heavy topic. Very complex and heavy topic, beta cells. I mean, I don't understand half of it, so I don't know how much I'm going to convince you about beta cell preservation. Third thing is, I think it's a postprandial state. Your beta cells are already stressed. And fourth, your speaker is also stressed. I woke up at 3:30 in the morning. I was in Bhubaneswar. And you can imagine 600 kilometers of travel. So if I say a few things wrong, pardon me. Are the slides on? Slides on, boss? So The topic is the slides. Are they here somewhere? अच्छा ठीक है ना ठीक है ठीक है तुम्हारी এটা কোথায় স্ক্রিনটা করা ঠিক আছে Beta cell preservation, the holy grail in diabetes management. See, when we manage diabetes to prevent acute conditions and chronic complications. You heard a lot about SGLT2, DPP4, GLP1, that is focusing only on those two yellow bars, nephropathy and cardiovascular disease. I know there's some cardiovascular people as chairpersons, but diabetes is much more than that. Diabetes has got microvascular complications, diabetes acute management for DKA, hyperosmolar state, preventing amputations, preventing infections. I think infections are one of the most common problems of type 2 diabetes, which the Western world doesn't face much. So they don't harp on it too much, but in India, we do face a lot of infection. And diabetes management is just not beta cell preservation. Diabetes management is holistic management. Please manage the blood pressure. Please manage the lipids. Please get them off smoking. Please get them to exercise. Please get them to control their diet. And I don't think you and I alone can do that. You need a team. If you don't have a team, if you're seeing 40 diabetic patients per day, I don't think you're doing service to management of diabetes. You have to spend time with your diabetes. The word is educate. So today we're going to focus only on glycemic control. That's why I put that slide up first. Now, today's talk is being sponsored. You know, there's a sponsored session by Novartis. So I am under contract with Novartis. So that is my disclosure to you. So whenever I talk about a DPP4 inhibitor today, I will be saying vildagliptin. That does not mean that vildagliptin is the only DPP4 inhibitor. Under the incretin groups, you have all the GLP-1 receptor molecules. GLP-1 are the least prescribed anti-diabetic drugs in India, but almost all of them are available to you. Liraglutide, dulaglutide, even oral semaglutide. So any of the three GLP-1 receptor agonists and all the DPP4 inhibitors. So what is the main problem with diabetes management after you managed your hypertension, hyperlipidemia, get them off smoking, put them on an antiplatelet therapy, is glycemic control. It's an important treatment goal. Diabetes is progressive. We are unable to maintain glycemic control. You heard Dr. Kollan that, and we get increased micro and vascular risks. Now, despite well-defined treatment, you heard about so many molecules. You heard about sulfonylurea, metformin, GLP-1, DPP4. Despite that, look at that figure. 76.6% of type 2 diabetic patients in India have poor glycemic control. Why? Just ask yourself, why? Why? This is data, ICMR data. You look at this and you feel ashamed. This 2022 data, if you see on the left-hand panel, number of people in India, this is self-reported diabetes, almost 6,000 people. This is a good cross-section survey, scientifically taken cross-sectional analysis of patients. Only 1/3 have glycemic control. Only about half have blood pressure control. I think this is too good. I don't think even half have got good blood pressure control. And if you take the lipid control, only 4 out of 10 have got good lipid control. Why? Ask yourself. What's so difficult in managing lipids in a type 2 diabetic patient? The talk you had about PCSK9, that is for very, very few rare patients. Why are not 80 to 90% of our type 2 diabetics have the lipids control? Who's going wrong where? Ask yourself. Now, but I'm not going to focus on the lipids and the blood pressure. My brief is on the glycemic control. So why do we have only 1/3 of our patients getting good glycemic control? Many reasons. We promptly blame the patient. Patient beta khai, patient beta ushud khaina. But look at yourself also. Apne garwan mein jhaak ke dekhiye. We have inertia. We don't increase our the treatment as we should. But having said that, let's be true to ourselves. Even in the patients in whom we work really hard, we still can't get good glycemic control. Why? Because there's this condition called progressive decline in beta cell function. The holy grail of type 2 diabetes management. So this will be the way we go. Beta cell dysfunction. We all know that insulin has got 2 phases of secretion. The moment you eat, there's first phase of secretion, and then there's delayed second phase of secretion. And beta cell function is the critical determinant of type 2 diabetes. We know beta cells. I mean, it's so surprising. Why has God given us so few beta cells? You know, He's given us 2 kidneys, 2 adrenals, 2 hemispheres in the brain, 4 chambers in a heart. But He's given us so few beta cells, so few. Small part of the pancreas, in the islet, so many beta cells from such a small component of that. If we had more beta cells, I wouldn't be talking today, right? We wouldn't have had problems with beta cell loss, beta cell function, dysfunction. But unfortunately, that's how it is. Maybe it's evolution. I don't. So there's islet cell, beta cell degranulation, there's reduced insulin content, reduced plasma insulin, and of course you have insulin resistance and you have the fatty acid aspects. Now this slide you've seen 100 times. If you haven't seen, please see it, because this is the natural history of diabetes. Our cardiologist colleagues will tell us that we define diabetes incorrectly. Professor Shubhankar Chaudhary was telling, isn't it? We define diabetes based on microvascular complications. Why has this magic figure of 7% of HbA1c come? Because large epidemiological studies have shown that at 7%, suddenly your incidence of retinopathy starts going up. But that's the wrong way of defining diabetes. Diabetes is not a microvascular disease. Diabetes is a macrovascular disease. So maybe we should be diagnosing diabetes much earlier, HbA1c of 5, 5.5. By that time, already the atherosclerotic process is already on its way. But then there you go. That's how we define diabetes, HbA1c 6.5. And by the time you're defining diabetes, you can see the red box, 50 to 80% reduction in beta cell function. Mind you, it's not mass, it's beta cell function. And why is there beta cell failure? The word is beta cell failure. When I say beta cell failure, there are three components to beta cell failure. First is loss in beta cell mass. There are autopsy studies. I won't say very well done, autopsy studies, which have shown that by the time you have long duration of diabetes, let's say 8 to 10 years, you've lost something to the tune of 40 to 60% of your beta cells. But that is not sufficient to cause diabetes. You still have 50% of your beta cells. Take the adrenals, 90% has to go before you get adrenal insufficiency. Take any other endocrine organ. There's a lot of reserve. So if you had 40% of beta cells, that should have been enough. But that's not the only problem you see. It's not the mass which is gone. After that, there is loss in function. So whatever remaining are there, they are functionally not able to secrete enough insulin based on the ambient glucose level. And third thing which happens, three things happen. Third thing is de-differentiation. Your beta cells, for some reason, lose the capacity to release insulin because they change their character. And this de-differentiation story has come a lot now after we started talking about the word reversal is wrong. We should use the word remission of diabetes after bariatric surgery and after low-calorie diet. So these are the three things which are happening. So why do beta cells die? Primarily partly aging, partly apoptosis. And why is the beta cell dysfunction? Because of two reasons, main reasons, glucotoxicity and lipotoxicity. That's why I asked Alan the question, that if you have new onset diabetes, try to get your blood sugar controlled very rapidly in the first 4, 5, 6, 7 days. Don't wait for, the ADASD guideline, give metformin 3 months, give SU 3 months, give some other drug 3 months. By that time, you've done enough damage to the beta cells. You won't see it today, the patient won't see it today, but what the patient will see is 8, 10 years down the line when he or she will end up on being insulin. Professor Chaudhary was mentioning, isn't it, that nowadays we're delaying insulin therapy. You could delay insulin therapy even further if you can get your diabetes control done well. Lipotoxicity, that's a very important mechanism of beta cell dysfunction, beta cell failure. And we ignore the lipotoxicity part. Why was I saying that start insulin a little bit early in diabetes? Because only 2 drugs which take care of the lipotoxicity part. One is insulin, and the other one is TZD. Spironolactone rose is not available to us. The rest of the other drugs do not act on the lipotoxicity pathway, so to reduce the free fatty acids. The other things we can't do much. If we get glucotoxicity and lipotoxicity under control, we can reduce the endoplasmic reticulum stress, mitochondrial dysfunction, oxidative stress, islet inflammation. I'll come to the drugs when I talk about drugs. We'll discuss these various. So these mechanisms are important. You need to know why the beta cells are failing. There are various stages of beta cell dysfunction. I think this one I'll leave because we have to quickly finish to get Zimbabwe out below 180. So there's higher degree of beta cell dysfunction is associated with poorer glucose control. This is a given thing. The studies have been done. I've put this study called beta decline study, but let's not go into the details of the beta decline study. Now, beta cell dysfunction in type 2 diabetic patients. You must have been to many meetings. You must have heard Dr. Mohan speaking, Dr. Ramachandran speaking. For some reason or the other, we Indians, unfortunately, are at a disadvantage. We have more beta cell dysfunction as compared to our Caucasian counterparts. When I say this statement, don't take it as a sweeping statement like we Indians, we Indians are very many Indians. We have a lot of ethnicities, we have a lot of states. So when I say we Indians, that does not mean every Maharashtrian or every Bengali or every Tamilian will have beta cell dysfunction. But generally, whatever studies have been done, we find that we have early beta cell dysfunction, more beta cell dysfunction happening at an earlier age in Indian patients. As you saw that initial pathophysiology slide, insulin resistance goes up and then insulin resistance peters out. The reason diabetes happens is because your beta cells are not able to secrete increased amount of insulin. That's when insulin deficiency, relative insulin deficiency in type 2 diabetes and absolute in type 1 diabetes, you end up getting hyperglycemia. So the Asian Indian phenotype is characterized by onset of type 2 diabetes at a younger age, greater abdominal obesity. So somebody was saying, Sattam was saying YY paradox. That was primarily for increased fat in Asians, and early decline in beta cell function. So we need to do something. The holy grail is to do something to prevent this beta cell dysfunction. Can we prevent the age-related loss? We can't do that. But can we reduce glucotoxicity and lipotoxicity? Yes. The various groups of anti-diabetic, Professor Shubhanga Chaudhary used the word classes, the various classes of anti-diabetic drugs we use, there are only 9 classes, of which about 6 are available to us. Which of these classes of anti-diabetic drugs will help us in restoring? Restoring will be a very, what you call, optimistic statement, maybe preventing the decline of beta cell function. Now, why did I say it's a complex topic? Because many of us still do not know how to assess beta cell function. We cannot assess beta cell mass, because there's no such imaging as yet, which can tell you how much beta cells you have. As it is, you have so few. You just have less than 1 gram of beta cells in your body. So how do you assess that? By a PET CT, by an MRI, by a CT scan? No, you can't do that. Are there any antibodies on the beta cell that you can tag, like we do all those radionuclide scans, the somatostatin receptor scans? Unfortunately, you don't have something like that for beta cells. So we cannot assess the absolute number of beta cells in a living human. If you're dead, of course, you can get your pancreas out and see how many beta cells you have. Those were the autopsy studies which show that 40 to 60% of beta cells are lost in advanced type 2 diabetes. So there are a lot of functional studies which are done. Most of these studies are difficult to do. Most of these functional studies are done in research labs or in labs which are interested in this. The first one is called hyperinsulinemic glucose clamp study. Very, very hyperglycemic clamp study. It is very difficult to do. You need to have a lab, you need to have a nurse, you have to do frequent sampling, you have to run a dextrose drip, you have to measure insulin. The other one is IVGTT. You give intravenous glucose, you do very frequent sampling of glucose and insulin, and then you can find out your beta cell function. The other ways are called, again, glucose potentiated arginine stimulation, done in research labs. The only one which we do, and we should thank Dr. Matthews for that, from Oxford way back in 1985. You must have heard this word used very often in talks, called HOMA, homeostatic model for assessment of beta cell function. It's a lot of work done by him. Hats off to him. Is it a very good way of assessing? Let's read the fasting measures. Time taken is probably a few minutes, because it's just to take a fasting glucose and a fasting. Does it directly measure the first and second phase insulin? No. Concurrent measure of insulin sensitivity? Yes. It's the simplest and least expensive test, because you just have to do a fasting insulin and a fasting glucose. Do you have to do a lot of thinking? No. There's an app on the web. You go put your fasting glucose and fasting insulin value. That will calculate your HOMA-B. HOMA-B is the function of the beta cell. It will calculate HOMA-IR for you, which is the insulin resistance. But is it direct measure of beta cell function? Answer is no. Now, coming to beta cell function, as I said, start from lipotoxicity, and let's move from left to right. So what works on lipotoxicity? As I said, insulin, TZD, incretins to some extent. Because not DPP-4s, but GLP-1s reduce the fat, what you call visceral fat. So it does reduce a little bit of the free fatty acids. Immune modulators are still on the research phase. Autoimmunity, inflammation, yes. That's why insulin is a very good drug. We heard a lot about insulin not to be used, but I think we want to preserve your beta cell early on. Insulin is the drug, because insulin is the only drug which is reducing the glucotoxicity, which has got anti-apoptotic activity, it's got anti-inflammatory activity. Let's come to islet amyloid. I don't think TZDs do so much, but it's listed in the slide. Incretin effect, yes. We'll come to incretins a little bit more. Insulin resistance, the only drug which works is TZD. Metformin is not really an insulin sensitizer. Metformin is primarily reducing the hepatic glucose output. So maybe it sensitizes the liver to the insulin. And of course, any drug with hyperglycemia protects your beta cell. So coming to, there are basically two drugs of all the classes of drugs that we use for managing diabetes, there are only three classes, which protect or reduce the stress on the beta cell. One of them are the incretins, GLP-1 and DPP-4 inhibitors. Second one are the TZDs, primarily by reducing the free fatty acid levels. And third one, as I said in the beginning, it's insulin. So incretins, the concept is propelling the move from glucose-centric to beta-centric concept of diabetes management. When I come to my last concluding slide, I will show you why DPP-4 inhibitors should still be in an armamentarium. DPP-4 inhibitors have almost been wiped out from the Western world. They almost don't use DPP-4 inhibitors anymore. But in Asia, we use it quite a lot, partly because probably we respond better to DPP-4 inhibitors as compared to our Caucasian counterparts. And the other reason is the beta cell salutary effect. How much salutary effect? Let's see. Now, as I said, Novartis is sponsored, so the word is vildagliptin, but there are studies with sitagliptin and GLP-1 receptor agonists as well. Now, these are difficult studies to take you through in the postprandial state. Should I try? Okay, let me try. Look at the left panel. Left panel, let's go A, B, C, D. A, B, the other one is also A, should be C. On the A, the first panel, if you see on the left, so there's something called AIR. AIR is called acute insulin response to glucose, which tests your beta cell function. On the B panel, on the y-axis, if you see there's something called ACR. ACR is acute C-peptide response, again, assessing your beta cell function. The panel below that, which should be C, it says SI, which is called insulin sensitivity index. And then D is something called as disposition index. These are very complicated terms to understand. And I think both you and I, being clinicians, we don't need to understand so much. What is disposition index? What is AIR? Let's see the bars and let's move on. So what was this study? This study was 2 weeks of placebo. Then they got vildagliptin, read it as any DPP-4 inhibitor for 6 weeks, and they got 2 weeks of placebo. You see panel A, the bar is a little bit higher. So acute insulin response improves with just 6 weeks of vildagliptin. The acute C-peptide response mirrors that, so that also improves. Your insulin sensitivity index also improves, and your disposition and the way you dispose of your glucose, which is indirectly telling your beta cell function, also improves. Now, improvement in insulin sensitivity, which is beta cell function, with vildagliptin. 53 type 2 diabetics who were treatment naive. They did not, when they are on metformin or they are on something else, the whole study becomes. These are people with type 2 diabetes who are naive to any treatment. They were given vildagliptin, 50 to 100 milligrams once daily. And I'm not comparing with teneligliptin. So if you see changes in parameters after 3 months, HbA1c fasting plus plasma glucose obviously improves. So don't need to see that because that's not the brief today. The brief, as I told you, is HOMA-IR and HOMA-B. I told you again, HOMA-IR and HOMA-B are basically very easily derived if you just do a fasting glucose and a fasting insulin. You and I do not do it regularly in my clinic. I never do it because I don't need this information. But if you're in a research setting, of course, you need this information. So HOMA-IR is telling you insulin resistance, which, as I told you, after a certain point of time, it becomes steady in the pathophysiology of diabetes, unless and until you suddenly lose a lot of weight or you're using a TZD to reduce insulin resistance. So see, at baseline, your HOMA-IR is 3.56. At 3 months, it's 3.27. Again, these numbers don't matter much. Just see the percentage change. So with vildagliptin or a DPP-4 inhibitor, you reduce insulin resistance to some degree, but as is obvious, it's not an insulin, it doesn't work on insulin resistance. That's why if you see the p-value, it's 0.075. So you can say the study is justified. It's not, they played with the figures and it could have also improved the insulin resistance. They didn't do that. And now if you come to HOMA,
Sorry to interrupt, sir.
HOMA-B is the beta cell function.
Conclude in 2 minutes.
Okay, I'll just finish. I'm almost coming to the end. If you come to the beta cell function, there is an improvement in beta cell function. So the therapeutic efficacy of DPP-4 inhibitors, HOMA-B and HOMA-IR, we have just discussed. And you heard about this trial called the VERIFY trial. This is a very interesting trial. It is early combination therapy with metformin and DPP-4. In this case, it was vildagliptin. They used it for 5 years. You heard all the data during the debate of DPP-4 and SGLT2. Those of you who were here, you saw all those slides. This slide is showing you how it worked. It worked by increasing the HOMA-B, the beta cell function. Now, to preserve beta cell function, I think what we need is early combination therapy. This is a topic very close to my heart. If you see a type 2 diabetic tomorrow, even with an HbA1c of 6.5, please start combination therapy, because the purpose of treating type 2 diabetes is not the glycemic control, but you want to preserve the beta cells so this guy does not end up on insulin 8, 10, 12 years down the line. The only guideline which supports combination therapy is the AAC guideline published revised even in 2022. This one has already been done, the verified trials. I don't need to go into that. The best combination therapy trial is by Dr. Ralph DeFronzo, where they use metformin, pioglitazone, and exenatide, and they showed that if you use combination therapy, you get good glycemic control. And this slide tells you why that happens is because of preserved beta cell function, not improvement in insulin resistance. This is something which we wrote, available in Professor Sadiko's textbook of medicine, various combination therapy. My request to you is, if you see a new onset type 2 diabetes, HbA1c is more than 9%, there's a lot of beta cell damage happening. Do not prescribe a metformin and a sulfonylurea and say, come after 3 months. Glycemic control will happen. Yes, you have not done anything wrong. You will get the blood sugar control, but the beta cell function, the beta cell mass will reduce. And this patient, if you had managed the patient aggressively, you could have prevented him or her going into insulin for 20 years. That patient will end up on insulin in 8 to 10 years' time. You won't know it, the patient won't know it. So in the initial part, if sugars are high, especially fasting is high, start a combination therapy. And to me, the best combination therapy is metformin, GLP-1, and a pioglitazone. And because we can't use GLP-1, best combination therapy would be metformin, DPP-4, and SGLT2 inhibitor. So this is my summary slide, just 2 slides. Type 2 DM is associated with progressive decline in beta cell function. Differentiate between function and mass. Early intensive glycemic control is associated with improved long-term morbidity and mortality. So please hit hard. Dr. Kalyan Ganguly said that 5 times. I'm saying it the 6th time. Hit hard, hit early. Remission of type 2 diabetes. Please don't use the word reversal. A lot of reversal word is being used. That's wrong. Remission of type 2 diabetes is seen with very low calorie diet, intensive insulin therapy. I did not go into that data, and bariatric surgery. Why? Because of the improvement in beta cell function. The greatest benefit is observed when interventions are delivered early. So please get out of that ADA-ESD mode of starting metformin, wait, start another drug and wait. Hit early, hit hard with combination of drugs. If at presentation HbA1c is 9.5, I see people with 14, 15, 17% HbA1c first presentation. Please give them some insulin in the beginning part. Try to convince. Just say that I'm starting this insulin for a very short period of time. Because insulin is the only drug which is anti-apoptotic, anti-inflammatory, brings down your glucotoxicity and brings down your lipotoxicity. All 4 mechanisms which damage the beta cell function. You need not continue it for a long period of time. The moment the lipotoxicity and glucotoxicity comes out, the beta cell function begins to improve. With that, I'll stop. Thank you.
We have constraints of time so that we can take questions later on, or we take questions simultaneously.
If you take now, I can watch the match.
Just hold on for a little time. Dr. Dilip Kumar, please. Dilip, I think he's a loving brother. Profession, senior intervention cardiologist, Medica Hospital. Dilip is academic all through, and he had been sharing and speaking at various podiums, holding workshops. So with him, and still now we do, except the COVID period in between. Please.
Thank you, Dada. I think sir was very right. Amongst the scholars, we are the 2 cardiologists. We are interventional cardiologists dealing with devices and wires and catheters. So the topic given to me is getting best of GDMT in HFrEF patients. So let me begin with the patient. This was a gentleman who had refractory heart failure, and he was admitted 3 times in last 9 months. And you can appreciate the valve motion is not proper, rhythm is not proper, and there was a leak in the mitral valve. So this patient had a atrial fibrillation, normal coronary arteries on angiogram, ejection fraction of 28 to 30%, and he was having recurrent heart failure on all GDMT. Obviously, the patient presented late, the GDMT was started late, But what to do finally is a lot CRT, that was a left bundle optimized CRT with AV node ablation. And this is what we got, CG of narrow QRS, and patient improved. And these are some glimpses, like a heart failure patient finally ends up like first on left upper side with a CRTD, then a TAVI, then AF ablation, finally last patient with a LVAD. So the idea of showing these patients is not that we boost interventional cardiologists, that we do so much fancy work. An idea how much cost would these 3-4 patients will be having getting these therapies done. It must be around, it is around, LVAD costs 75 lakhs, a TAVI costs 20 lakhs, AF ablation costs 5 lakhs, a CRTD costs 10 lakhs. So this is the burden, economical burden of patients. Finally, a heart patient he is going to incur. And this is not easy and not for all patients. And that is why only few patients, they undergo these kind of procedures. Majority of the patients, they die if we don't give them GDMT. And that is why heart failure remains an intractable clinical problem with higher mortality, even higher than all of the cancers combined. So getting best out of GDMT in HFrEF patients should be the goal right from the beginning. And you can appreciate the Indian data on mortality of heart failure. With HFrEF patients, mortality becomes very high with passing time, provided we don't act early and we don't act faster. So lack of GDMT was one factor which is, which kind of gives us an idea the trajectory of these patients. You give them a guideline-directed therapy or a suboptimal guideline-directed therapy. You can see the curve of these patients, the Kaplan-Meier curves diverges like this. So a HFrEF patient not on GDMT present with 29% hospitalization, 21% higher risk for CV-related hospitalization, and 26% higher risk for disease. So look at this chart. I think we all are familiar with the slide. To deal with patients who are having stage C and D heart failure with HFrEF. So these patients require ARNI, beta blockers, MRAs, SGLT inhibitors, and diuretics as needed on board. And that should be as early as possible. Maybe to diagnose these patients, 4 to 6 weeks is the cutoff where you should be having on these drugs on board. Maybe you can titrate it in next 6 months. And if the patient worsens further, you can look for possibility of doing a CRTD or finally a LVADs or a cardiac transplant. And ACC 2022 very clearly recommends ARNI as the first line therapy in all symptomatic patients. And there are multiple, terminologies are there. Chronic heart failure with decompensation, heart failure. What are these? So, and what is the status of ARNI in all these patient population is very important to know. And look at these 3-4 scenarios. There only a subtle difference is there, like chronic HFrEF patients, we all know, somewhere 2-3 medications coming to you, you are adding some medicines, and that is where a paradigm heart failure trial was done, and which really, transcripted the journey of ARNI in heart failure patients. Hospitalized HFrEF patients with decompensation. De novo means patient was not diagnosed. All of a sudden, he is decompensated coming to hospital, and patients with diabetes. All these category of patients, you see, ARNI works. This is the paradigm heart failure. We all know the rule of 20% reduction in primary composite endpoints, CV death, heart failure hospitalization. And Indian patients were also included, something like 500 in paradigm heart failure patients, and they showed a similar benefit, equal to the same results. Once you start these medicine, ARNI in hospitalized patients with decompensation, you reduce it by 42% the CV death or rehospitalization. And that is why sacubitril valsartan is recommended by ACC 2021, EAC 2022, and EAC 2021 in all these category of patients with decompensation and de novo patients as well. You can appreciate early initiation you start and then get a 46% reduction in those patients who were NAV with ACE inhibitors or ARBs. So all these category of patients, I'm not going in detail, whether it is de novo, decompensation, chronic heart failure patient, ARNI should be there on board right from the beginning. And this is also very important. Diabetic patients. So our diabetic patients are worse than normal patients, and the similar benefit is reflected in these category of patients as well, 20% reduction. And there's always a two-way traffic is good. Two-way authentication is good. You see on Facebook, if you have only one-way authentication, then you can be lost. You can be hacked. So there can be a OTP and something, many, two-way authentication needs to be done. And that is why it is very, very important that once you start sacubitril valsartan, once you stop it, then the things should be reversed. And that is what is there with ARNI. You see the gain in the ejection fraction, you stop ARNI, you see again there is a loss of ejection fraction in these patients. And also it acts on HbA1c, reduces the HbA1c. And with all medicines, if you up titrate ARNI, you may feel that you are doing injustice to patient, your ejection fraction, you are not getting on board a 200 milligram twice daily of ARNI, so you don't get disheartened. It happens in 64% of patients only, and that too in 26 weeks time. So don't get disheartened if you start ARNI and you are fiddling around 550 BD or 100 BD. And this is what I was telling, a two-way authentication, increase in ejection fraction. And if you stop the medicine, the mortality goes high by 4.7 times. And that is very, very important. So continuation of sacubitril valsartan improves cardiac function. Say a patient with 35% ejection fraction, you started him on all these 4 pillars of therapy. Now he's having a 55% EF. Now we start withdrawing drugs. Is it a wise thing to do? Absolutely no. You should be refrain yourself in doing this thing. And once you stop the sacubitril valsartan, at least you are going to reduce 6% ejection fraction in 3 to 6 months. So imagine if you stop after 2 years, what will happen to these patients? They will go back to their previous status. And this is NYHA functional class. If you continue, you gain the in the NYHA functional class status. And if you stop, you go back to same situation. Finally, with ARNI, we all know, we have seen, but 2 important drugs which are coming on board and which are there staring at us. And one drug is available with us, that is Virasuguat. We have started writing this drug. I will give you, if I think I have 8-9 minutes time, the brief history from where it all has come from. You see, if you admit a patient, and inpatient, the fees and the remuneration to doctors are a little higher than OPD basis patients if you treat. So in the US, these heart failure patients were getting recurrent hospitalization in 2000, 2008, 2010. And this was noted by the government, it was noted by the Medicare agencies. And what they did was, they started a break, putting a break on this recurrent hospitalization. Maybe it was physician guided, a little, symptoms like exertion, dyspnea on exertion, little worsening, they are admitting this patient. So they started putting penalties. So these doctors, you see in India, we don't have any check. You do 20 towers, 18 die, but you are on top of the list, he's a tower specialist. It doesn't matter. It happens only in India. So in US, everything you do, your action and results are there on board, in the data, in the government data. So if your patients are getting rehospitalized, you are getting penalties. And from there, a concept of worsening heart failure patient came, where doctors, in idea of not getting their wrong image or a wrong data on board, they started treating these patients in OPD basis. They started having intravenous Lasix. Okay, you are having symptoms, come, you have reps, no problem. You be there in OPD, we'll give you Lasix for 46 hours, and then you improve, you go. So that was the idea of worsening heart failure. Worsening heart failure means a patient who was stable, getting hospitalized, or the patients who are requiring intravenous IV diuretics, which doesn't happen in India. We straightway admit the patients. And from where these patients were included in a study called Victoria trial. Worsening heart failure is this different subset of patients, and whether this new drug is going to act. All 4 or 5 pillars are there. What else we can do? The patient is not following criteria of CRT, is not going for a transplant. What will you do? Will you keep admitting these patients and getting a bad name on you? Let's work on Virasuguat, and that is where this drug came. And this acts independent of NO pathway, and it activates the GMP, and finally the energy is given to heart. And this trial involved worsening heart failure patients, and the result was something like this. P was 0.019. So all those patients who are worsening with stable, all 4 or 5 pillars of therapy, we can choose this drug as a class 2B indication. It is there in guidelines, and we should be aware. Finally, omecamtiv mecarbil. So if you have a heart failure with reduced ejection fraction, you would like to improve the cardiac function. Patient ischemic heart disease, revascularize. If you have a DCM, you give all these drugs. Lenoxin was one drug which was, positive inotropic. What else is omecamtiv? Is a drug which increases the actin myosin bridge, and it can enhance the cardiac function and has shown to increase ejection. Troponins, but finally, there is no arrhythmias have been reported in last trials. And galactic heart failure trial was just like Victoria, similar, inclusion criteria, worsening heart failure patients, and they also got benefit, 0.025. So these two drugs are staring at us. The Verquova is available with us, and then omecamtiv is still not available in India, but we can definitely avail the facility. More trials are on board. They maybe in coming years they can be in class 2A or maybe class 1. We don't know. And in last, when you go for a GDMT, you have to have a check. You can't be a genius. You can't be you have a team, you have your consultant, you have a junior consultant, but everybody can't maintain a record and cross-check it. This can be done only by a checklist, heart failure checklist, whether you are giving them the GDMT or not. This is what we in Medica we started. We were this third hospital in India to start Medica heart failure clinic with heart failure monitor. And you can appreciate all these patients were given this weight monitoring system, all drugs, what he is getting. If he is not getting a particular drug, why is he not getting? And if he is getting particular dose, why is not being escalated to the desired dose? So this is very important to go for a checklist and finally treat these patients with a proper GDMT. Otherwise, you may miss the mark and you send the patient to us carpenters to do a TAVI or a LVADs or a CRT. Thank you so much for the hearing.
Dilip,
I compensated a bit.
Huh?
I compensated a bit of time.
No. You
Yeah.
compensated a lot of time. But one thing, why did you not in a diabetic conference? Huh? थोड़ा सा बने time compromise नहीं करके SGLT2, it's a fight between cardiologists and diabetes.
This was sponsored from Novartis. They gave me this particular topic of
Okay.
you can imagine, understand.
Our next speaker, Dr. Anirban Sinha, please.
Dr. B speaking on the topic of hypoglycemia in non-diabetic adult. As we are all aware that hypoglycemia is common among children, but we will be learning the hypoglycemia on non-diabetic, particularly for adults. Over to you, sir.
Thank you. And thanks to the organizers to being back in Bdcon again after a long time. And I really enjoy the hospitality. And thanks again to the organizers, especially Rajan, who called me, and other organizers as well. So to start with, I'm given, and frankly, this is not a sponsored one. So this is more of an academic approach. And I'm trying to approach a very odd and maybe a slightly different topic of hypoglycemia we commonly aware of in this podium of diabetes. All the anti-diabetic drugs cause hypoglycemia, but what happens if the patient is not known diabetic and not taking any drugs on diabetic, apparently, and still the patient is having hypoglycemia, even sometimes documented. Sometimes many patients, you don't believe it, you deny the history and end up in serious consequences sometimes. So how to approach that patient? So to start with, maybe it may not be visible here because of the screen is small and my letter, there's a clutter of causes. I just wanted to show that how many causes it can be. to cause the hypoglycemia in a non-diabetic setting. That starts with drugs like alcohol, salicylates, quinine, haloperidol. Just to give you some examples, even the certain tumors and other dispensing errors, even the iatrogenic, but patient is taking erroneous medication, thinking that it is not a diabetic medication for non-diabetic patients, having access to it, psychological issues. There are many issues. And the septicemia and other issues also end up in hypoglycemia. So we just need to keep in mind these things. And before going to the approach, I will just show you some of our cases in medical college, which we see. Start with a 46-year-old female, non-diabetic, presented with recurrent episodes of hypoglycemia, majority after fasting of 8 to 10 hours, non-documented weight gain. So most of the time, hypoglycemia with excess food causing weight gain, no galacturia, there is normotensive patients, and that patient definitely have acanthosis. So Whipple stud were documented by diagnosis of hypoglycemia, and it relieved with glucose. So on biochemical workup, critical sample, that is blood glucose of 41 milligram per deciliter, insulin was 46, C-peptide was 7.2, beta hydroxybutyrate was 0, and post glucagon, there is a rapid rise in glucose. That is diagnostic. Some you understand some when you know the approach, and then serum cortisol is 13, which is normal. So it is hyperinsulinemic hypoglycemia has been documented in this patient. So what we understand, that patient has a hyperinsulinemia, and how to documentation and how to approach this patient. We may need, if the patient does not develop normal hypoglycemia in the stipulated 8 to 10 hours fasting, we can go up to 72 hours fasting. I will try to elaborate later how it actually done. Critical sample means less than 55 milligram per deciliter. Then we have to explain that insulin should be more than 3 microunit per ml. C-peptide is more than 0.6. Beta hydroxybutyrate will be low. And post-glucagon, there is a rapid rise in glucose for more than 25 milligram per deciliter in 10, 20, and 30 minute samples. That is very important. That is a brisk response that categorically shows that it is responding to the insulin-induced hypoglycemia. And serum growth hormone cortisol, as because these are also a counter-regulatory hormones, we need to have an access on this. An absent circulating insulin antibody in rare cases, which can also precipitate hypoglycemia. Insulin and insulin receptor antibodies both can cause this. So also at the very important time, because of the rampant availability of anti-diabetic medication in over-the-counter as well, and the patient on psychosis may have to simulate or fake the approach of hypoglycemia and get sick for other reasons. So factitious sulfonylurea intake should be excluded, and family history of diabetes with availability of anti-diabetic medication should be looked for other patients of non-diabetic hypoglycemia as well. So later on, we try to localize the lesion. Usual size of the insulinoma is around very small, 1 to 2 centimeter, mostly intrapancreatic, and rarely it can be duodenal wall, jejunum, almost less than 1% of the patients. USG abdomen, contrast CT, but these are very difficult sometimes in the small tumor or isosceles to the pancreas, then it is very difficult to detect. So this is our CT appearance of the patient. Let me try if the marker is showing. So this is the uptake you can see here in the CT arterial phase. This is the post-venous phase. Hunsfield units 162 and delayed venous phase, it comes down to 120 units. So we can see definitely uptake there. And to confirm the lesion, we try to go for an ultrasound, and we can see there is clearly a lesion here in the pancreatic head. Previously, the lesion was shown in only both pancreatic head and maybe in the uncinate process, but ultrasound clearly confirmed that lesion. And the ultrasound shows hypoechoic mass with distinct margin, and it is more on the head. MRI shows T1 weighted and T2 weighted, hypointense and hyperintense respectively. And we can see this uptake diffusion weighted image. We can see definite uptakes here, and detect insulinoma without hypervascularity is sometimes possible because isovascular is sometimes a situation. So restricted diffusion image, as we can see here, is characteristic of insulinoma and dotted, and not going in details of the isotope scans. So intraoperative pancreatic ultrasound is very important modalities, and angiography and arterial stimulation venous sampling is commonly sometimes done. I'm not going again in details because of short of time. So insulinoma is a beta cell pancreatic disease, is a part of the main one syndrome. We should be looking for other components of the main one, or it can be sporadic. So every patient of suspected insulinoma or a documented insulinoma, look for the other components of the main one. There are monomorphic cells with positive with immunohistochemical markers of synaptophysin or chromogranin A. Mostly we treat with surgery as our patient is planned for, and sometimes we can go for radiofrequency ablation or embolization. Or metastatic insulinoma, which is very rare, we can require palliative or diazoxide sometimes if the patient is not willing to operate, and chemotherapy sometimes been tried. So diazoxide is available at present, though it's quite costly. Coming to our second case, just to give you a varied presentation of hypoglycemia which can occur in a non-diabetic setting. This is a 59-year-old male with history of hypoglycemic episodes. On his examination, mucocutaneous hyperpigmentation is documented without any postural drops. So this is the pigmentation we can see here. We can definitely understand that cortisol levels are expected low, and as we can see here, 8 AM cortisol is 1.4 and 8 AM plasma ACTH is 759, which is characteristic of primary adrenal insufficiency. That is again a very important cause of hypoglycemia we need to be aware of. So these are bilateral enlarged adrenal of the same patients. Third patient, just to show you, a 58-year-old male, documented episodes of spontaneous hypoglycemia for the last 1 month, very short period. Normotensive acanthosis is there. Right-sided breast mass was documented on ultrasound and palpable. Critical sample analysis again, and blood glucose of 40, insulin less than 1, C-peptide low, beta hydroxybutyrate is 0.1. Post glucose is responding is 10 minutes is 73, 88, and 98. Serum cortisol is 14. We can see IGF-1, IGF-BP3 is also done. This is a patient, I'm not going in details of, this is a complicated one, but IGF-2 mediated hypoglycemia due to Phyllid's tumor of the breast. So this hypoglycemia again resolved post resection of breast tumor. So it's very odd thing which can end up in hypoglycemia sometimes. A Phyllid's tumor of the breast also can end up in any mesenchymal tumor, in fact, can presentation with hypoglycemia. So coming back to the causes and approach, 9. Okay. Insulin is the most common cause. Drugs as iatrogenic use, or I mean, maybe the patient is voluntarily taking it. And altered counter-regulation, sulfonylurea is to be considered. Again, some of the failures like hepatic failure and renal failure should be kept in mind. And these cause decreased gluconeogenesis and decreased glycogenolysis. All these things can increase hypoglycemia events. Some endocrinopathies, as we have shown, adrenal insufficiency, growth hormone deficiency, glucagon deficiency, though it is a bit rare, and multiple pituitary hormone deficiency like growth hormone, which are also a counter-regulatory hormones, can cause hypoglycemia. We do not forget the cause poisonings like ethanol, propanol, and salicylate, which is very commonly available, because ethanol inhibits the gluconeogenesis and hypoglycemia persists for around 12 to 72 hours after ingestion. So patient should be aware and should not send back home without precaution. There are neoplasm we have discussed, not only the islet cell tumor, mesenchymal tumor, hepatocellular carcinoma, adrenocortical tumors, carcinoids, leukemia, and lymphomas, and tumors which secretes the IGF-2 also precipitate hypoglycemia. So these tumors need to be excluded when primarily no other cause of hypoglycemia has been documented, as we have seen in the cases. Islet hyperplasia, so not only the insulinoma, the other forms of islet hyperplasia, that is the syndrome of non-insulinoma pancreatogenous hyperinsulinism, is been documented. That is considered as a budding of the islet cell from the ducts. We are discussing that downregulation of the beta cells, and we can see also the budding of the islet cell from the ducts, that nesidioblastosis, the new beta cells are being developed in a pathogenesis that results in excess beta cell that ends up in hyperinsulinemia and also cause hypoglycemia. That is mostly the post-meal hypoglycemia. That persistent hyperinsulinic hypoglycemia of infancy, though it is not an adult we are discussing today, but this is also a part of the genetic mutation of sulfonylurea receptors. There are autoimmune causes, as we have said in the beginning, that insulin receptor antibody and antibodies when the other causes are not found. And most of the patients have elevated ESR and ANA positive, which can be a clue for us. And release of anti-insulin antibodies, the release of inappropriate insulin release erratically that cause erratic hypoglycemia, that should be looked for instead of postprandial hypoglycemia. We all know of the symptoms, not going in details. There are adrenergic and neuroglycemic symptoms. What I mean to say that both the symptoms as happens in diabetic, also happens in non-diabetic hypoglycemia as well. So that includes altered mental status, lethargy, seizures, and even coma. And we have also discussed the fasting hypoglycemia, which is mostly the insulinomas and other tumors which cause the excess insulin secretion, or reactive postprandial hypoglycemia, the necidoversus and others. It is adult necidoversus is mostly the adult islets hypertrophy. It is mostly detected by, interestingly, it is 72-hour fast negative. We commonly say that fasting, fasting gives you an idea of insulin causes of hypoglycemia, but interestingly, non-insulin pancreatinous hypoglycemia, that is necidoversus, does not cause hypoglycemia in the fasting state, and it's more common in male compared to the insulinoma, which is more in female. It can be detected very easily by calcium stimulation test, and it may require partial pancreatectomy. Dumping syndrome is post-surgery patient is also a concern. Mostly occurs 2 hours after meal because of the rapid elevation of glucose, which triggers the insulin response that end up in rapid insulin release and cause hypoglycemia later on. This is a 72-hour fast, how it is done. Discontinue all the essential except non-essential medication, especially any medication which can affect your glucose. Collect the blood sample of the glucose, insulin, C-peptide, and proinsulin every 6 hours until the plasma glucose concentration is below 60 or maybe critical value less than 45 or 55. And the frequency of sampling should be increased every 1 to 2 hours. And this is way you can do the extended fasting state. And we look for the glucose concentration less than 45 and 72 hours is elapsed. And then if the plasma glucose concentration is less than 55, if the Whipple steroid is present, or the 45, less than 45, these are the considered positive for extended fasting test. And reversibility with the 1 milligram glucagon of 10, 20, and 30 minutes, as we said, rapidly occurs in the more than 25 milligram response has been documented with the insulinoma patients. So maybe a checklist of how the different causes of interpretation of 72-hour fasting test. We can see the exogenous insulin is increased, C-peptide is low, proinsulin is low, sulfonylurea antibodies are not detected. Insulinoma patients, proinsulin is raised, and so is the C-peptide and insulin. Sulfonylurea patient definitely test positive for the sulfonylurea. Insulin autoimmunity, we can get the insulin antibodies, and insulin erratic, insulin is low, but still there is erratic response of hypoglycemia because of insulin receptor antibody, and they also have insulin antibody negative. So this may be the one way of approaching the hypoglycemia in non-diabetic setup. Symptoms of the fasting of the skip meal or fasting hypoglycemia. If the fasting sugar less than 45, 72 hours fasting may not be needed, or if it is done, blood glucose less than 45, if the glucagon stimulation more than rise of more than 25 milligram per deciliter, then it can be insulinoma, or definitely we need to screen the OHA, or proinsulin more than 5, also suggestive of insulinoma. On the other hand, if the OHA screen is positive and proinsulin level less than 5, we also get a positive diagnosis of provisional diagnosis of OHA induced. So is the C-peptide values are equal, and the insulin value more than 3 and insulin glucose ratio more than 3, and then we go for C-peptide. If the C-peptide is more than 2, again, insulin is the most important culprit. If the C-peptide is less than 2, surreptitious insulin and anti-insulin antibodies should be looked for. Though insulin levels are high, insulin glucose ratio is increased, but C-peptide is low, then outside insulin is the cause, or maybe erratic insulin release from anti-insulin antibodies is the culprit. But if the hypoglycemia with the insulin less than 3 and insulin glucose ratio is less than 0.3, then hypothyroidism, liver disease, enzyme defects, protracted malnutrition, other islet cell tumor, as we have discussed, the IGF-2, IGF-BP secreting tumors should be looked for, which can cause the hypoglycemia without insulin. So this may be in nutshell to look for, and just to give few ideas of treatment, because the causes are varied, so is the treatment response is varied. Principles of therapy is that maintain the plasma glucose greater than 50, either snacks or IV dextrose. In many of patients before going for OT, even for insulinoma, we ask for frequent meals, and uncooked cornstarch, though it is available in the malls at present only, but not in the regular availability. Maybe the porridge or something can be given at bedtime to maintain the glucose level and avoiding hypoglycemia at night. Even in the insulinoma planning for the surgery, we can do it. Our second priority is definitely treating the cause. SIU is the removal of the drug, removal of the tumor, or reaction of the tumor, or maybe as the adrenal insufficiency, we can correct the deficiency. So is the treatment. In the presence of autoantibodies, though insulin receptor and can be treated with high dose of glucocorticoid to prevent the hypoglycemia, but the results are sometimes erratic. We should keep that in mind. Most asymptomatic hypoglycemia to mild to can be patient learns how to manage it themselves, like starting from taking glucose, tablets, juice, soft drinks, milk, crackers, candy, and we can encourage that. And commonly recommended dose of glucose is around 20 grams of glucose. And however, glycemic response to oral glucose is transient. So we should take the mixed meal maybe along with the glucose to avoid the persistent recurrent hypoglycemia. When the hypoglycemic is unable or unwilling to take the carbohydrates orally, so if the patient is stupor, seizure, or coma, or something like that, we can give. And in the patients of insulinoma especially, or the patient with insulin dependent, glucagon 1 milligram is very important response. And D50 can be given in the IV, maybe in the extreme situations. And there is not possible because of multiple metastatic tumor in the insulinomas, diazoxide in the dose of 100 to 800 milligram per day can be given. It is available at present in our country, in our state as well. But it is a prohibitive cost, I accept. So it may not be continued, especially the poor patients. So, but this may be used for the preparation of the patient for the surgery. Side effects also should be kept in mind, like hypotension, brain edema, gastrointestinal side effect for the diazoxide should be kept in mind. Other drugs includes the octreotide and calcium channel antagonist should be kept in mind for the treatment. And non-beta cell tumors with short-term treatment of hypoglycemia, mostly effective pending surgery done by the glucocorticoid or growth hormone as the counter-regulatory hormones. Remission of autoimmune hypoglycemia can be associated with immunosuppressive therapy. As I said, glucocorticoid can be one of them, but there is no big trial and response is again erratic. So with this, there is so much heterogeneous response with non-diabetic hypoglycemia with so different strategies depending on the cause. But end of the day, we need to avoid the hypoglycemia that can end up in coma and stupor. So with this, I end my talk here. Thank you.
Piyush, do we have time for discussion? I think
we can have some questions. So if there is any kind of question from the audience, we can take the questions. So I request the speakers, please come to the dais.
Speakers, please come to the dais.
Chair Terence.
Dilip, Dr. Mukherjee. Actually, this was a beautiful session. The ending, other sessions were good too. This was a beautiful session touching upon the everyday problems that we have. And the time allotted to the speakers because of any time constraints in any conference is too short to do a complete justice to the topics awarded to them, given to them. So any questions?
Any questions, please?
May I start the ball rolling? Dr. Mukherjee, please. This liraglutide is very, very favorite of the good endocrinologists. But for us, convincing the patient is a bit difficult because the Indians are loath to pricks and that too a costly prick. Do you think semaglutide will make the difference, oral semaglutide? Because data of semaglutide is not yet available with us.
To start with, I think GLP-1 receptor agonists are very good molecules. If you ask me, I think after metformin, the second line drug should be a GLP-1 receptor agonist. But that is in the ideal world. Ideal world, many things should happen. They don't happen. It's very expensive. And even in Apollo, I don't have a lot of patients on GLP-1 receptor agonists because they can't afford. I don't know how many of them here have been using GLP-1 receptor agonists. So once you've convinced your patient, what I do is I offer them both. I don't use liraglutide anymore. I use once weekly liraglutide or the oral semaglutide. Oral semaglutide is not that easy pill to take. It's not the panacea actually, because take it first thing in the morning, fasting, half an hour you have to remain fasting, can't take so many drugs with it, nausea, vomiting is there. So it's individual choice. I have patients who choose the injectable because it's once a week. And I have some who will die if they get an injection, so they choose the oral one. With regards to cardiovascular data, as you rightly pointed out, subcut semaglutide sustain 6 has the data. That was mostly stroke driven rather than MI driven. And oral sema, I mean, on stage, I have to say we don't have data yet. The reason we don't have the data was they did not do a dedicated cardiovascular outcome trial. The Pioneer 6 was part of the regulatory trials where they were trying to get the molecule registered. So they're doing this whole trial, which will come out in 2024. You know that very well. So what do I tell my patient? I mean, I don't go into so much detail. I mean, the first thing is pocket the first 9 out of 10 nahi, so the GLP-1 stops. I have seen prescriptions where GLP-1 have been written by your cardiology colleagues. You know some of them, and the patient takes it for a month.
Is very.
Patients take it for a month or 2 months and then they stop. I think that's wrong. If you're trying to give GLP-1 receptor for benefit, they need to take it at least for a year or 2. Otherwise, there's no point. You know, you are just.
The same happens with the PCSK. The cholesterol
lipid
levels come down, and they
you are
stop
just being the salesperson for the pharma company. You see, if you want to help your patient, then GLP-1 receptor agonist therapy has to be sustained. Otherwise, the entire cardiovascular outcome trial data, the shortest was 1.8 years, longer is 3 years. So what's the point of giving it for, active prescription patient? What's the fun in there? So yes, they're good molecules, but unfortunately, the cost is the issue. Thank you.
Yeah, maybe we don't have data on whether the whole of the effect of the GLP-1 analogs are reversible after 1 or 2 months. We don't know. I mean, most of the people do not take it, but is the benefit is sustainable? We don't know. And regarding the cardiovascular outcome, they take the molecule as a cardiovascular benefit, both an injectable semaglutide or oral semaglutide. So they are at par with the molecular characteristic compound. Injectable semaglutide and cardiovascular effect goes well for the oral semaglutide, at least theoretically, and convincing to me to a certain extent. Thank you.
And a little bit of clarification on my side. Dr. Ganguly just he asked me why you didn't touch SGLT2 inhibitors. What I am going to teach or say anything about SGLT2 inhibitors in this gathering. And living side, beta blockers, MRAs, SGLT2 inhibitors are now proven beyond doubt. ARNI, still the hesitancy is there with many physicians, even endocrinologists, they don't write. And I wanted to give a flavor of changing definitions of heart failure, what is worsening heart failure, the drugs which are coming up. So that was basically the idea driven, not to discuss much of SGLT2 inhibitors. Yeah.
No, I told you as a part of GDMT.
So actually, ARNI is a wonder drug. This is acting very good, but price is the issue. So we will.
No, not price is not the issue. I'll tell you. The whole issue is last decade saw at least 2 good molecules. ARNI is one of them, and the second is obviously SGLT2 inhibitors, which have really caused change in the life of the people. Now, when the heart failure presentation, he has said, it can present as an acute situation, or a patient comes to you, you diagnose that the patient is in a heart failure, reduced ejection fraction. When you have an acute presentation, obviously you will have to use diuretics. Here, while you are using full course diuretics, I know a few of my colleagues start ARNI at the same time. I start a little later, because once you start ARNI, go low on the diuretics. By the time the patient is a bit stabilized, you go low on the diuretics. Other drugs that you use, you are not using ACE inhibitors. Beta blockers you are using, you can cut short on the aldactone antagonists once you up titrate ARNI. So the total cost of therapy vis-a-vis the routine therapy with reduced hospitalization almost comes to same with optimally dosed. And one more thing, which I liked his presentation, because we are interventions, don't think we are trying to push intervention on you, but CRT early, we started at stage 4. If CRT started at stage 2, there is reverse remodeling. So the long-term cost benefit of heart failure management, all the drugs come down and you are basically on ARNI and SGLT2. You have cut down on diuretics, you have cut down on ACE inhibitors, you have cut down on beta blockers because you have put in on a CRT. The total conglomerate therapy along with reduced cost of hospitalization comes to the same.
At the same time, Dada, it has also started a debate. Like once you have ARNI on board, it has conclusively proven that ejection fraction goes up. We have seen our patients. So someone who is 34% EF, and now you are planning a stage 3 heart failure, stage 2 heart failure. Now, after 3 months, still ejection fraction 34%. And now we feel that CRT should be done. Should we wait for another 6 months for ARNI to work? 3 months is enough or not? So this debate is now ongoing, and a lot of things are changing. Yeah.
Because initially what happened
Right, sir. And one or two points more. A fear of renal failure, maybe in SGLT inhibitors or ARNI, is really gone. With more than 500 prescriptions of ARNI from me, and SGLT2 also similar, maybe 200, 300. AKI and worsening kidney disease is not the factors. I think it just work in opposite way. Give you 2-3 months, and then you feel that you see that creatinine starts going down rather. What is your?
Absolutely correct.
Maybe just to ask you that how early you want to start ARNI in acute heart failure? I mean, is there any data on guidelines?
Once the patient is off IV diuretics, off inotropes, then before discharge, 24 hours before discharge, you can start. No.
IV diuretics we use at the most 24 to 36 hours.
Good evening.
Yeah. So this is a DPP-4 symposium, so I think we'll need to talk a little bit about DPP-4 inhibitors. So as I was saying, it's because my talk was beta cells, right? So my job is to get the message across that beta cell preservation, reversal of remission of diabetes. So main is lifestyle, weight loss. That's the best treatment for diabetes. And after that is incretins. Incretins, we discuss a lot about GLP-1, and as we said, most of your patients will not be able to afford the GLP-1 subtractants. So if they can't, then the next best is a DPP-4 inhibitor. And as I was saying, in the Western world, they moved away from DPP-4 because it's a very weak anti-diabetic drug. We all know 0.6 to 0.8% reduction in HbA1c. But the reason to add a DPP-4 to your therapeutic regimen is probably the beta cell salutary effect. So that's why in a combination therapy, metformin, SGLT2, DPP-4, I think, that's my opinion, makes a little bit of sense. This could be a debate. So I think the diabetologist here can start.
Yeah, I may have one point here. Is there any comparable data of beta cell survival or beta cell functional improvement of DPP-4 versus the other anti-diabetic agents? HOMA beta data. Yeah, is there any comparable of SGLT2 DPP-4?
I don't think so, but the grade, no, we don't have, but the grade, let's hope in grade they have done the beta cell function, and I think subsequent publications of grade when they come probably will be exciting because they have all the 4 molecules there except SGLT2 is missing, unfortunately. So the whole grade trial, I hope we all know the grade trial. The grade trial was new onset diabetes, metformin, what next? This is the big question in the field of diabetes. Unfortunately, they did not add on SGLT2 because by the time they designed the trial, SGLT2 was not available. So they've again compared subclaviculia and the others. So maybe if some data comes from their beta cell function, it'll be nice. But I hope we don't disagree that incretins have a beta cell salutary effect as far as...
Any drug which reduces the glucose level improves the beta cell function.
Fair enough, but these were...
This is I think this should be the concluding question. So many endocrinologists on board. Do you still write sulfonylureas? And will you still go on writing sulfonylureas? Right. Then why? Because that is the only drug that causes hypoglycemia. That is the only drug that...
You'll have different views. So 1, 2, 3 views you will have. Okay. I'm in the ideal world.
Good evening, sir. Me, Dr. Rajiv from Durgapur Steel Plant Hospital Department
Yes, sir.
of Medicine. Sir, after each diabetes conference, there are so many learnings for us. Just I want to know that diabetes can be reversed or not?
Okay, the question is wrong. You can remission now. Just go Google today, diabetes remission. You will.
But I mean, there are different definitions of this. What is remission? What is reversal? There are different.
Just Google remission ADA. You will get the whole paper. It's free download. Download it and read it. That will tell you much more than what three of us will tell you. Having said that, reversal means what? Reversal means you've cured the disease. You've reversed the disease. You can't get the dead beta cells back. You can probably get some of the functionality of beta cells back. You can get some of the de-differentiation back. So what happens is if you do bariatric surgery and you follow them up, the Swedish cohort, they followed up for 10 years, not all of them were reversed. It comes back. So what you do is you get remission. You get your blood sugar values. See, what is diagnosis of diabetes? A very at random fasting 126, PP 200. Where do these two numbers come from? I said that based on microvascular complications. So you get those values below, numbers below those values. And you say, I have reversed diabetes. No, you have not reversed diabetes. You've got diabetes into remission. Now, the same person, if he gives off low calorie diet, gains a little bit more weight, or bypasses all the benefits of bariatric surgery, diabetes will come back. Reversal means divorced. So that doesn't happen. So it's gone forever. It doesn't go forever. So the word is remission. Yes, you can get remission. You don't need to do all these high-fi things. Just lose 10% of your body weight. Just 10% of your body weight and see. Cardiologists will go out of business. Endocrinologists will go out of business if people can lose 10% of body weight. Now, there are many ways of losing weight, and low-calorie diet is one of them. Now, low-calorie diet, there's so many types of low-calorie diet. Intermittent fasting, continuous 15 hours, 3 days a week, 5 days a month. There are so many ways of doing what you call low-calorie diet. So if all of us in this room promise not to have the food we had this afternoon.
Sir, one last question, sir. Sir, nowadays the stem cell transplantation for so many diseases are going on. So can you please highlight some transplantation benefit for this diabetes?
This is a very big area of most of the modern science, because if we theoretically, if we can regenerate the lost cells, we can, your term of reversal is possible. So people have tried. Stem cell transplantation has been tried with the islets, insulin beta cell transplant. And in my knowledge, only SCPGI, not SCPGI, PGI Chandigarh had tried with the hepatic beta cell transplant. But unfortunately, that result was not very assuring because maybe the technical constraints or others. But this is a very promising in the other part of the world, and many people are doing it. Pancreatic, there are different types of stem cell transplant. Maybe the whole pancreatic stem cell transplant, maybe the beta islets transplant, maybe the beta cell transplant. And there are many ways of stimulating the beta cells back, and whole thing is in the process of evolution. So most of the trials are not very successful, but also they did show the remission, not the reversal of the diabetes up to the 1 or 2 years in different studies. So it is a very good option in future, not now at present maybe.
So thank you, Dr. Anirban.
This is
Thanks.
This is a very difficult question. So my views will differ from all of this. So let me say it. See, what is the pathophysiology of diabetes? You have the 8 pathophysiological defects, right? You have incretin deficiency, insulin resistance, beta cell failure. You have lipotoxicity. You have the brain neurotransmitter deficiency. Now, anybody in this room can tell me any one of these 8 pathophysiological mechanisms being taken care of by sulfonylurea. Any one of them. No? So that straight away tells you, you see, you should not be using sulfonylurea if you follow science. So my answer is not over yet. Huh? If you follow science. But then what is the purpose of treating diabetes? As Dr. Kalyan Ganguly said so many times, is to get glycemic control. So sulfonylurea, probably by reducing toxicity in the initial parts, may have some role in management of type 2 diabetes. So whenever I talk about UKPDS or the STENO2 trial, what they use there, they use sulfonylurea metformin, human. Why? Because that's what was available to them. If they repeat the same trial, UKPDS, which will never happen probably, or a STENO2 trial with the newer molecules, DPP4, metformin, SGLT2, or GLP1, maybe we might we might reverse diabetes inverted commas. But in real practice, Dr. Mukherjee, what percentage of your patients are on a sulfonylurea? In my clinic, still 40 to 50% of my patients are on sulfonylurea. If you go to UK, 40% people are on sulfonylurea. Go to US, 40 to 50% people are on second line sulfonylurea. Why? Because this was the first molecule, is being used for so long, it's cheap, there's a lot of data. The two things which you're worried about, hypoglycemia and weight gain, Dr. Kullan, all of you were present when Kullan was giving his talk. He told you, see, the hypoglycemia with the second generation sulfonylureas, or if you want to call them third generation inverted commas, glimepiride or gliclazide, if you teach a patient well, I think the hypoglycemia is not that much of an issue, sir, with gliclazide specifically, and probably with glimepiride also. And the weight gain part was all old data with glimepiride, chlorpropamide, all that. The weight gain, if you take the advanced trial, almost for 6 years with a gliclazide, weight gain was almost zero. So weight gain and hypoglycemia story is probably, if you don't use it properly, of course, if the patient takes the sulfonylurea and misses his or her meal, of course there will be hypoglycemia. But if given an option in a real world situation where money is not a problem, then probably my choice would be metformin GLP-1 and an SGLT2. If money is a problem, metformin, DPP4, SGLT2. And if sugars are very high, some patients cannot even afford, say, I mean, still the cost, you see. I mean, the DPP4, the cheapest would be how much? 8 rupees. SGLT2 cheapest is still 10 rupees. So 8 plus 10, 10 plus that comes 25 rupees per day. There will be people who will not be able to afford 25 rupees per day for anti-diabetic medication. There may be sulfonylurea in that form. Okay, so
thank you. Thank you, Dr. Mukherjee.
Yeah.
Concluding. Okay, so that was a very nice interactive session. We all enjoyed a lot. So big round of applause. We are coming to the end of this session. So there will be a felicitation ceremony. And I request our chairpersons to felicitate the speakers. So Dr. Ganguly, kindly felicitate Dr. Dilip Kumar. Yeah. Dr. Arunangsu Ganguly, he will felicitate Dr. Dilip Kumar. Thank you very much. So now I request Dr. Rajan Palui to felicitate Dr. Mukherjee.
Okay.
Thank you very much. Thank you very much, Dr. Mukherjee. Thank you, Dr. Raj. Now I request Dr. S.N. Chakravarti to felicitate Dr. Anirban Sinha. Thank you. Thank you. So thank you all the chairperson. Kindly be on the dais. So I request Dr. Amita Biswas. Yeah. Kindly felicitate our chairpersons. Dr. Thank you very much, Dr. Rajan, Dr. Bodhan. Now I request Dr. Amitabh Vishwas to felicitate Dr. Asian Chakraborty. So thank you all the speakers and all the chairpersons. That is a very nice session. So thank you everyone for making this function a grand success. Thank you everyone.
Next, we have the quiz, the all exciting part that we have been all waiting for. And from the prelims, we had 10 groups who had participated in the prelims. And out of that, we have been shortlisted 4 out of that 10 who will be participating in the rounds. And for now, the session to Dr. Bodhan Dashmunshi will be our quiz master.
Hello.
Hello. A very good evening to everyone who have come out here. I must thank the organizers again and all the seniors, all the participants who have stayed back for the quiz. The most exciting part of any conference, the postgraduate quiz. So we had a very exciting prelims. There was one clear-cut qualifier with 12 points out of 15, but there were 4 teams on 10 points. But as luck would have it, we can only have 3 teams from those 4 on the final stage. And we use the star marked questions to the top 3. So let's see who are in no specific order. So we have the lottery for your sitting arrangements. So please come one by one and pick up your chit. Okay. So team B, Dr. Apurv and Dr. Neelde. Can you have a big round of applause to the audience? ছোট ছোট চিট ওই দিকটা একদম ওই দিক। Then team C, Dr. Amit Kumar Singh and Dr. Anvesha. So you have to pick up your lot. This is no specific order. D, Dr. Arnob and Dr. Raghul. Chit. So come and pick up your chit. Okay, so the order of sitting will be 1, 2, 3, and 4. Then we'll go opposite 1, 2, 3, and 4. So 4 will be the last. 1, 2, this side. The 4th team is Dr. Ashwini and Dr. Raghul. So can we have them out here? I would request everyone who is behind to just come in front quickly. Can we have mics for the teams? 3, 4. So I would request the organizers to distribute papers to each of the teams. Stage. That's because okay, so the 4 teams, you have picked up your chits. 1, 2, 3, and 4. We'll have clockwise, anti-clockwise rounds, and I'll be winding it up in 45 to 50 minutes max. So, are you all ready? Can we have the everyone in front, because there are audience questions also. It will be difficult for us to go there. Can we have a microphone for the audience? Someone to go around? कोई माइक के साथ दौड़ने के लिए? So let's start off. Are you all ready? Can we hear? Thank you. So let's start off for the Bdcon quiz, which is on diabetes mellitus. So simple rules, 4 rounds, round specific rules. Mostly we have clockwise and anti-clockwise, pounce and bounce. Do you all know the concept of pounce and bounce in a quiz?
No.
Pounce and bounce. Bounce মানে ball drop করে আরেকজনের কাছে যাওয়া, আর pounce মানে থাবা দেওয়া. So in pounce, the concept is if the question is asked to team 1, I'm explaining the rule. If the question comes to team 1, suppose, then if you know the answer, all of you can raise your hands and write the answer on the paper given to you. Don't answer on the mic. If your answer is correct, you will get plus 20. If your answer is incorrect, you will get minus 10. For direct question and for bounce, what is bounce? The normal passing. Suppose they are not able to answer, no one has raised their hands, so the second team gets the chance, then the third, then the fourth. The team which raises the hand and pounces, they don't get a second opportunity for the question, for the same question. Is it clear? Everyone in the audience, is it clear? Thaba dewa or drop, all drop kore jawa, bounce and pounce. So that's what we are starting off with. So round 1, it's about the history of diabetes mellitus, and you can see a lot of timelines out here. So let's come to the first question. Rules remain the same. It is clockwise. So 1, 2, 3, and 4. I'll ask you to answer, then only you answer. Please take the papers in the blank sheets of paper. Please distribute the blank sheets of paper. 1 blank sheet to each team. So pounce has negative. Negatives, again bounce, no negatives. Bounce is, suppose the question is asked to team 1 or team A, and team A knows the answer, but before they answer, I'll give 10 seconds for all of you to raise your hands. That is pounce, P. Now, if you raise your hands and answer correctly, how correctly? You have to write the answer. No answering on the mic on pounce. If you write the answer correctly, you will get your plus 20. If you answer incorrectly, you will get minus 10. Now, suppose 2 teams have pounced, but they haven't pounced. So if you are unable to answer, the question will go on a bounce to them. The question, if they're not able to answer, it won't come back to teams 3 and 4. Whoever answers last or whoever gets it last, the next team, the next question goes. So it does not follow 1, 2, 3, 4 always. So the first question might be to team 1, but depending upon the bounce strategy, second question might go to team 3 or 4. This is to ensure equal opportunity for all. Okay. So starting off with the first round, first question from history of diabetes. Sir, would you like to sit this side? So first round, sir. Okay. You can bring your chairs this side. I think this will be easier for you all. So this is a person from India, as you can visualize. So history of diabetes in India, a JAPI article 2021 by Dr. Mohan and team identified this diabetologist who was the first to use insulin for the treatment of diabetes mellitus in India and named the institute in which he worked. So for pounds, remember, if you know both the parts, then only raise your hand because negatives are there. Half answer, negatives. So question to team A, anyone ready to pounce? Your pounce closes in 5, 4, 3, 2, 1, closes. So now answering on the mic. You can answer on the mic. No negatives for you now.
I don't know.
Okay. Always take a chance in quiz. Team B.
Dilip Maulanavish.
No. Team C. Team D. Anyone from the audience? Okay. So the first person to use insulin in India, according to the article, Dr. J.P. Bose, Dr. Jyoti Prakash Bose, and he worked in the School of Tropical Medicine. Okay, so in Kolkata, a Bengali person who used also Tamil Nadu history is there, but 1 year later. So no score, no points. Again, because all teams have tried. The first question was direct to team 1. We'll go to team B right now. Okay. Second question. This product was the first of its kind to be introduced and used in India for the treatment of diabetes mellitus in 1924. Mention the specific name of the product. So if it's like surf and washing powder, you have to mention surf, washing powder. Washing powder or surf won't fetch you the full marks. So question to anyone ready to pounce? Pounce closes in 3, 2, 1, 0. Take a chance. Okay. What is this? You can see, read this. Everything is there written. At least half point you could have got. Question to team C. Take your opportunity. Team D. Team A. No negative. On the mic.
Insulin of Eli Lilly company.
Okay, insulin is correct. Okay. Now I wanted the specific name of the product. Okay, so insulin will not give you the marks. So they have on the mic. They have mentioned Eli Lilly. So the answer is incorrect. So let's see what the answer is. So Amitabh, AB de Villiers or Amitabh Bachchan. So the insulin was called the AB insulin, which is Allen and Hanbury Limited and the British Drug House Limited. So AB insulin was the insulin which was introduced. Okay. So no one from the audience, no one from the... So big round of applause to the quiz master because no one is answering yet. We move on to the third question. Again answered. Okay, a simple one. This molecule A was discovered in the 19th century by Bdcon and Stas. Its mechanism mellitus was first enumerated by the Baron, whose name means it's the picture B, which will be coming up, and its derivatives role in the modern era of diabetes mellitus treatment can be linked to C. So A, B, C. A, name of the molecule, B, the original, and C, the person who will be coming up in the picture next. A, B, and C. A is the molecule, B, the person who identified, C, now you will know who. Okay, question to team C. Anyone for the pounds? 5, 4, 3, 2, 1. Team C, any answers? I move on to team D. No negatives. On the mic, please. Take a chance. You should take a chance because if you have attended since morning, you should know. Okay, on the mic. Switch on the mic. Thiazolidinones. Okay, then A, B, C. Which one is thiazolidinones? A. Okay, B. Any answers? C at least. That's why you put B or C. A and B or C will fetch you the marks. So we move on.
बेरन था ना
हाँ ना उसका नाम क्या है B is the picture so उसका नाम okay
MacLeod MacLeod
not MacLeod anyone I've all teams covered question was to team C anyone from the audience it's A B or C and sir knows A and C so that would have served the marks mic to sir okay Dr. Ralph DiFronzo. Yeah, fluorescein, that's the chemical structure of fluorescein. And von Mering, who founded the fluorescein way back 130 years back. So, applause to sir and Dr. Shubham for getting it correct from the audience. Audience, you can mark +10 for the audience. Okay, so we can see at the end. Last question to team D again because no one has got. So, this is the explanation. Okay, this is the easiest question of the lot. And if you have been attending this conference since beginning, you should get this. A particular property of molecule X, which will be coming up in the was pursued by French physician Jean Stern, who first reported the use of the molecule X for the specific property which was studied in 1957. The history of molecule X is linked to Galega officinalis. This is the giveaway. It was rediscovered in the search. Identify the molecule X. The clues follow. This is the easiest question of the quiz. Afterwards, I'll come to the audience. So, Shamal, you can mark for the audience also. Yeah, group 4. D, group D or
Exenatide.
Exenatide. Incorrect. We'll go to question. I've not given the commoner name of Galega officinalis. Okay. Team Artesunate. No, this is a diabetes quiz. So maybe some other molecule could have been there. Team B. Team C, sorry. Anyone from the audience? Not hydroxychloroquine. Okay, the answer is absolutely. So this was the talk by Dr. Shomar Banerjee sir yesterday on metformin. So the easiest answer of the quiz, metformin. Okay. So now we have one more question. We'll ask because the questions like this will ask the team. And if no one answers, then we move to the audience. Okay. This is the last question of this round. This stamp was named Scott number 3701, which was released in Guyana in 2002. This stamp depicts the son of a clergyman born in Scotland who studied biochemistry in Germany. So many countries, Guyana, Scotland, Germany. He investigated about electric shock and the bacteria that causes tuberculosis also. He studied about that. So why are we discussing about this stamp in a diabetes quiz? Question to team A. This is open, so the clues are confusing, but the picture gives the answer. Look at the picture properly. Okay, team A, anyone for pounds? No pounds. Team A, any answer? No. Team B? Team C? Team D? Okay, anyone in the audience? Pardon? Huh? Naam to likha achhe. That's why I told, look at the picture properly. Everything is written, but it's blurred. Okay, so she had given the same answer for the last question. So it's Dr. John James Richard MacLeod. So that's the answer. Everything was there in the picture. You just needed to look at it. So first round over. I think no scoring. Only audience has scored. So let's move on to round 2. Round 2 is about clinical diabetes. Same will follow, but this time we'll go anti-clockwise. Okay. Scoring points, scoring systems remain the same. The first one, there's a typing error, not 2600, 260 it will be. So this patient who is there in the clinical pictures came for some other purpose. The fasting was 210, PP was 260. And the patient is undergoing iron chelation. What is the diagnosis over here, which we want to talk about? Let's see the pictures. Team D or 4, because this is an anti-clockwise round. I want the specific name, or if you give the proper explanation, that will be sufficient. Pounds. Okay, plus 20 to team B. So the opening scoring, they are opening the scoring of the quiz, plus 20. Team B. I want the specific term. You're correct, but you have to go to one term beyond. Okay, plus 20 to team A. Team A plus 20. Anyone? Three teams plus 20. So let's come to team D.
Hemochromatosis.
Okay, absolutely correct. So this is secondary hemochromatosis resulting in bronze diabetes. So all teams open their accounts with this question. Plus 10 to team D, plus 20 to ABC. Okay, now we move on to the next. A 20-year-old with newly detected diabetes, blood pressure was elevated, muscular build. Question to team C, sorry. On examination, there was hepatomegaly. Lab investigations revealed hypertriglyceridemia, elevated liver enzymes, hyperuricemia. The pictures are shown out here. What could this be? What could this be? Anyone for the pounds? Pounds? Okay. Minus 10 to team D. Minus 10 to team D. Pounds closes in 3, 2, 1. Okay, team C, please answer on the mic. On the mic.
Acromegaly?
No. On the mic? No answers?
Klinefelter?
Not Klinefelters. For passing on, no extra time. So anyone in the audience? Anyone in the audience? This is actually a case report which is there on the net. So basically this was a familial partial lipodystrophy syndrome. So if you had given anything of secondary diabetes lipodystrophy, I would have given you the marks. Okay. So the question was to team C, right? Now question to team B. Okay, the favorite question. A 42-year-old African obese male present to the emergency of a Kolkata hospital. So here you can take the hospital in a drowsy state with fasting plasma glucose of 300, postprandial plasma glucose 460, with ABG revealing pH of 7.1, bicarbonate of 12. Type 1 antibody profile was negative. That's the clue. He had family history of type 2 diabetes mellitus. He recovered with insulin and was switched to OHs, with which he is presently maintaining glycemic control. mention the specific name diagnosis. Why named? Because I want from this picture, I want the specific name of this.
KPD.
I'll come back to you, but you had. Okay, they had raised their hands. So I'll plus 20 to team C. Because I wanted the specific name, I'll come back to you. If no one else answers, I'll come back to you. You want to improve the answer? They have given the term I wanted, specific term.
Latent ladder.
No, you have given the answer.
Okay.
Come back. My discussion now whether to give you points or not. KPD, answer on the mic. So they also answer KPD. Then Brook-Manhattan disease is incorrect. So the term I was wanting, can you answer on the mic? Team C, they have given the correct answer.
Flatbush diabetes.
Flatbush diabetes. Flatbush is actually a suburb in Brooklyn, New York. So the name comes from that. I'll give, we are in a relaxed mood. That's why I'll give plus 10 to them. Okay, they have a direction, I have plus 10 to them. Because they, technically it is correct. So plus 10 to them, plus 20 to team C. So Flatbush diabetes was what the term I was wanting, but because conceptually you are correct, so I'll give you the marks plus 10, plus 20 out here. So next question to team, next question to you, right? Okay, 56-year-old male, 20 years of diabetes, comes with tingling, numbness of lower limbs, biotheciometry, 45 volts on VPT, fundoscopy, retinopathy present. One picture is coming up. Identify the investigation which has been done. I'll come to the audience after, if no one. So pounds. Minus 10 to team B. So I won't come back to them. Anyone else for the pounds? No? So one answer from you all, please.
Arterial Doppler.
Not arterial Doppler. I guess it is now there in Kolkata also. Okay. Anyone? No answers? Pass. And you have pounced. So the answer is confocal corneal microscopy. Okay, CCM is the investigation. I'll skip this question, an easy one. So let's move on to round 3. Quickly we'll be doing now. Again clockwise, but quick ones. Okay, identify this complication of long-standing diabetes. What is the name of the classification used to assess its severity? Quickly. So please answer on the, anyone on the pounds? No?
Charcot's arthropathy.
What? Please answer.
Charcot's arthropathy.
No. B, C, D. Anyone in the audience? Okay, so this shows limited joint mobility and the Brinks-Starkman classification, which is there. Next question to team B. Identify this complication of diabetes. Can you remove the timer? Very well visible. What is the name of the anatomical classification system based on the site of involvement of foot, which is used for classifying this? So I just want the classification name, easy one, and the part answers will be accepted, except for pounds. Anyone on the pounds? No one on the pounds. So
Diabetic foot. Name of the complication.
Specifically, no. Means it is a part of diabetic foot, but you have to be more specific about the specific complication. Any second part? No. Team C? Team D?
Charcot arthropathy.
Charcot's arthropathy. Okay, part A is correct. Second part. So team D can take a chance. Team A can take a chance for the first part. Second part. So anyone in the audience? No. So Charcot's foot. So +5 to team D, and the Sanders-Frigberg classification. Okay, that's the name of the classification. C, right? So this is a renal biopsy specimen showing certain features. So focal lobular round to oval mesangial lesions with an acellular hyaline matrix core rounded peripherally by sparse crescent-shaped mesangial nuclei is shown in the picture. Name the specific lesion found in diabetes mellitus. Pounds. Okay. Please write your answers before I come. Your handwriting is unclear. Write in block letters. Okay, +20 to team B. Question is to, wait a minute, I'll come to them. This is +20. So I've taken your answer. +20. What? You want to expand this? Not. They were partially correct, so I am using my discretion and not giving them a negative marks. So can we have the answer?
Kimmelston-Wilson lesion.
Absolutely, Kimmelston-Wilson lesion. They were like K was incorrect, Wilson was correct. Others +20, +20. B and D +20. Team C +10. Okay, so the next question goes to team D. Okay. Identify this complication of diabetes mellitus as directed in the imaging and name any one of the 3 most common organisms causing this condition.
Emphysematous pyelonephritis.
Wait. You're giving the way. So you have raised your hand. Time over. For pounds, you have to raise. Okay, I'll come. Okay. +20, team C. Not totally correct. Anyone? So you have pounced, +20 to them. Anyone else pouncing? No. Yours was? So you can answer on the mic.
Emphysematous.
Emphysematous.
Pyelonephritis.
Absolutely correct. Emphysematous pyelonephritis is correct. Second part is not totally correct.
E. coli.
E. coli, what I was wanting, but you could have given the other names also. I could have accepted which is more acceptable. I said the main 3. So this comes at 4 or 5. So +10, -10 because they have pounced and not got it correct. +20 to team C. -10, +20, +10. Okay. So that brings us to the end of this round. Okay. Question for the audience. Okay. Anyone can answer. Open lot. Please tell.
The blade technique.
Okay. The foot plate method. Okay. The plate method. So let's come to the last round of today. No, we have 6 questions. Welcome to the rules. 6 questions, 90 seconds, correct response 10 marks, no negative marking. So can you have the score at this moment? I need the score at this moment because I will go from the lowest to the highest. The timer will be required right now. তাড়াতাড়ি করে দিচ্ছি আর 5 মিনিটে শেষ করে দিচ্ছি quickly.
Okay, group A or group 1 total marks till now is +20. Group 2 is +30. Group 3 +70 and group 4 +35. So group 3 is
first lot, second lot, third lot, Fourth lot.
Yeah.
Okay. So questions to team A. Okay, you
yes.
get 90 seconds. Are you ready? Now, answer on the mic. True or false? Nobel Prize in Medicine Physiology was awarded to Banting and McClure in 1921.
True.
Incorrect. Name the drug associated with Saver-Timmy 53.
Pass.
Now, BMI for labeling underweight is fill in the blanks.
Less than 18.5.
Okay, plus 10. Expand FCPD.
Fibrocalcific pancreatic diabetes.
Hmm?
Fibrocalcific pancreatic diabetes.
Okay, plus 10. HNF4A gene mutation is linked to which MODY?
MODY 1.
Plus 10. Name the once weekly acting GLP-1 analog. There are quite a few now. So, name any one correct.
Liraglutide.
Liraglutide, no. Incorrect. So, you still have time. Name the drug associated with Saver-Timmy. You've got 3 correct so far. So, plus 30. Other 2 you have answered incorrectly. Name only. Time is getting over. Name the drug associated with Saver-Timmy.
Sitagliptin.
So answer is incorrect. So plus 30, I guess, to them. So the first answer is false. It was in 1923. The drug associated with Saver-Timmy is saxagliptin. And name the one thing you can could have given Sema also. Okay. Any once weekly oral dini, any would have been acceptable. So, Saxa. So we now move on to team B, right? Timer, your time starts. True or false? Frederick Sanger was awarded the Nobel Prize in Chemistry in 1958 for his work on the structure of proteins, especially that of insulin.
True.
Correct. Name the drug associated with Carmelina trial. Correct. Plus 10. BMI WHO for labeling normal weight is
18.5 to 24.9.
correct. LADA.
Latent autoimmune diabetic in adult.
Okay. Plus 10. GCK gene mutation is linked to which MODY?
2.
Correct. 10. Name the ultra long acting insulin.
Degludec.
Correct. So all correct. Plus 60 to team. Wonderful. Plus 60 to team B. Now questions to team D. Question to team D now. Ready? So get scores, because what's the score right now? Team D. Team D. What's the score right now? There's 50, 90. You are on 35, you are on 70. So team D, get ready. Mike, your questions start now. True or false? Metformin received FDA approval in 1994.
True.
Correct. Name the drug associated with award 1 to 6. Trials, obviously.
Pass.
Okay, BMI WHO for labeling overweight is? Fill in the blanks.
25. More than 25.
2.
Third one, sir.
Okay, expand DSME. I'll come back to it.
Pass.
HNF1A gene mutation is linked to which MODY?
MODY 3.
Correct. So plus 10. Name the once weekly DPP-4 inhibitor. There is one which has been approved. There was one which was supposed to come out, but you can name either. I'll be happy to give the marks. Time 21 seconds. You can go to any of the questions you have not answered. You've got 2 correct, 1 and 5. You have passed all the rest, so take a guess. Some guess you take.
6 saxagliptin.
No, saxagliptin is incorrect. BMI
18 to 22.5 is normal. 22.5 above.
Time up. So metformin, they were correct. Name the drug with award 1 to 6. Dulaglutide, BMI WHO 25 to 29.9. Expand DSME, diabetes self-management education. HNF1A, they got correct. 3. And name the once weekly DPP4 inhibitors, Trelagliptin, or something which was supposed to come out, Omarigliptin. I would have accepted. So 2 correct answers, right? 1 and 5. So 20 points. So let's review. Score 50, 90, 55, and 70. Let's see if they can. So either they will win or they will win. But all are winners at the end of the day. So let's come to the last final deciding question set. On the mic, please. The time starts now. True or false? The first insulin analog aspart was launched in 1996.
False.
Correct. Plus 10. Name the drug associated with credence trial.
Canagliflozin.
Correct. BMI for labeling morbid obesity is incorrect. Expand AD. Correct. Plus 10. PDX homeobox gene mutation into which MODI?
MODI 4.
Correct. And which sulfonylurea is approved for the use in gestational diabetes mellitus? So if you have attended the sessions, everything is here.
Glimepiride.
So you can come back, or you have answered everything? No, second. So first one you have got correct. Second one you have got correct. Third incorrect. So it's over. Plus 40 to them. So I think we have the results which are quite clear. So everyone is a winner. Thank you to the organizers, Amitabh sir, Rajendra, Amotoda, Rakesh da, and Shomik sir, who is not here, and everyone who gave me the opportunity. I think the results will be as follows. Okay. So team A, they finish up with 50. Huge round of applause for them, please. Team B comes third in the quiz, or the second runners up with 55 points. Huge round of applause, please, for them. Team B narrowly misses out on the first prize with 90. So huge round of applause for them too. And the champions for 2022 Bdcon Diabetes Mellitus Quiz, Team D. So Team C, okay? So can you just name the institutes from which you all are quickly?
Bardhaman Medical College.
So Bardhaman Medical College, all the alumni who are out here, they will be very happy. Then
Bardhaman Medical College.
Bardhaman Medical College, second prize. Third,
DSP Hospital.
DSP Hospital faculty are here. And team 4, DSP. So it's a wonderful thing to qualify even for the finals. So thank you everyone. নামগুলো একটু ওখানে গিয়ে ব্লক লেটার্সে লিখে দাও সব। থ্যাংক ইউ।
স্যার এই মাঝখানে পোস্ট অফিস প্রাইস দিয়ে হ্যাঁ বলছো হ্যালো now we are going to announce the winner of our poster presentation. In the meantime, while they're preparing certificates for the quiz contest, let's have our third winner for the poster presentation. Dr. Rajiv Kumar, please have a loud round of applause for them. Please come on the dais and receive your certificate. Laptop, sorry. Sorry, laptop. Please, sir. And to felicitate Dr. Rajiv Kumar, I would like to invite Dr. Rajan Poloida and Dr. Amato Sankarda for certificate. Yeah, third prize. Any guess for the second prize? Any guess for the second prize? Any guess? Dr. Shavik Das for second prize. Please give a loud round of applause. Dr. Shavik Das to please receive his certificate. Bakura. I think someone on his behalf may. Kundu sir ke dilei hobe. And the first prize goes to Dr. Arnab Bhattacharya. May we give him a great round of applause. Dr. Arnab Bhattacharya, please come on the dais and receive your certificate and a cash prize of 2,000. I thank all of you. Any conference is incomplete without the participation of PGT students. From next year, we will plan something big, something more grand. So I would like to convey a message to all of you that please go home and convey a message to your friends that from next year, this type of program will be a major part of our conference. Prize will also be a big, and the consolation prizes will be there for the second and third prize also. So thank you all of you. Do we have certificates ready for the quiz? Biswa sir, please join Amartoda and Rajanda and give, honor our champions of which contest. Rajanda, please. Third prize winners, Dr. First prize, Dr. Apurva Deokulihar and Dr. Neeldeep Panigrahi. Third prize winner. Please come on the dais. Great round of applause for them. And promise us that you will come back again next year. Second prize winner, Dr. Anvesha Shorab and Dr. Amit Kumar Singh. Please welcome them. And we want commitment from all of you that all of you will come back again. Number. Yes, more participation in quiz and more posters. And the first prize, Dr. Arnab Kumar Bhattacharya and Dr. Rahul B. Please A great round of applause for them. And to conclude this program, I would like to thank on behalf of Bengal Diabetes Foundation. I would like to thank all our esteemed speakers and chairpersons who traveled from different parts of the country and enlightened us with their words of wisdom. I would like to thank all our delegates who attended Bdcon in large numbers and made this conference a great success. You know, speakers doesn't matter, it's the audience which matters. And active participation from audience is the key driving force of every. So thank you, a special thanks to all our delegates present till the last breath of this program. I would also like to thank our BDF members who have worked behind curtain and made this program a success. A special thank to this program really program a reality. Thank you. A special thanks to Sun Pharma, Novartis, Abbott, USB, Torrent, Eris, Intas, Lupin, Elchem, MacLeods, Corona, Apex Pharma, Microlabs Limited, Aristo, Mankind, Bollinger Ingham, Zydus, Roche. Thank you, friends. Without your active participation, we wouldn't have been able to make this become a reality. Thank you from the core of our heart. And lastly, this vote of thanks is incomplete without mentioning the hardship of our ground support and city residency for the help and tasty food. Thank you. And promise to come back again next